Hello, Prof. Nasir. Hello.
Leo, shall we start or wait?
Hello.
Shall we start or wait?
Nasir, Prof. Nasir. Professor Kato is in the attendee, please. Can invite her to the panel?
She joined already.
She's in the attendee, please.
So shall we start the webinar?
Can you invite her to the panel?
Invited Prof.
5回病棟、5回病棟。コードブルー、コードブルー。5回病棟、5回病棟。
What happened to Prof. Nasi?
Professor Yuko Kato, thank you for
Hi, how are
joining
you?
the meeting. We are honored. Actually, we are now live. We are doing live stream, and the meeting already started. Would you please start the webinar by your welcome note?
Yes. Should I start?
Yes, please.
Oh, thank you so much, Professor Naziu. And also, we are so honored to have this ACNS webinar. So this time is Africa-Asian collaboration, Egyptian, the women neurosurgery. But this evening we have so lucky because we have 10 speakers, which very maybe some good information for the young doctors. So the topics is very variety of the field, vascular and also the spine and the pediatric and of course women neurosurgery, the topics. And also the Dr. Danielov from Russia will talk about AI. So we are very, very happy to listen. And of course, I would like to thank you very much for Professor Nazil, give us such a wonderful opportunity. Thank you very much. And maybe we want to listen. The honored the guest is President Gans, Dr. Moody. Thank you so much.
Thank you very much, Professor Yuko Kato. Sharon, I think you are going to give a welcome note.
I think let's make it quick because we are running out. I mean, it's a bit late. So I think I'm very happy today to be here in this tripartite seminar together with the YNS team, together with Prof. Yusuf. It's a great honor for the women in neurosurgery to get this platform to able to showcase our ideas and also our own specialities. Okay, so thank you very much.
Thank you very much, Leo. You'd like to say a welcome note before I start to say my speaker?
Proceed, Professor Nasir.
Thank you very much. Ladies and gentlemen, it gives me great pleasure to welcome all of you in this special event, Current and Future Directions in Neurosurgery, which is a tripartite seminar, which is a joint meeting between three organizations, the Asian Congress of Neurological Surgeons, the Continental Association of African Neurosurgical Societies, and the Egyptian Society of Neurological Surgeons. This is an important collaboration between two continents, Africa and Asia, in the field of neurosurgery. Let me first express my sincere appreciation to our great Professor Yuko Kato for giving me such opportunity to be the main organizer for this meeting with my two colleagues, Dr. Sharon Theophilus and Dr. Leo. And I'm happy to work with both of you, and I would like to thank all of you for the hard work we did while organizing this event. Let me welcome all our distinguished speakers who are joining us today and giving important lectures. I would like to thank all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. On Friday, 26 March 2021, we had an important event, which was the inauguration of the Egyptian Women in Neurosurgery. And this was done under the support and supervision of Professor Yuko Kato. We established the group of women in neurosurgery, and the chairman of the group is Nihal Shaban, and we have two chairperson, and we have two chairs, Dr. Heba Azouz and Rihab Yahya. In Egypt, we have very few number of Egyptian women in neurosurgery, and this is the distribution among the different universities The total number is 21, which is very few. When we go back to history, we can find that Egyptian women were leaders in all specialties. This is Queen Hatshepsut, and as you can see that she was ruling Egypt, and this was during the 18th dynasty. She was named foremost of the noble women. When we go back again to the recent history, you can find that Egyptian women were leaders in everything. This is Samia Musa. She's one of the well-known Egyptian women in nuclear medicine. She was a scientist. It was 1965. Egyptian women work as pilots. They work in all fields. When we look at women as doctors in the medical field, we can find that the Ministry of Health in Egypt, she's a woman, and both the Dean and Vice Dean of the Faculty of Medicine at Cairo University, both of them are women as well. This photo during signing a memorandum of understanding, me and Mahmoud Qureshi, president of the CANJ, and this agreement was to train African trainees in the Faculty of Medicine, Cairo University. It was done July 2019. When we look at my family, this is my daughter. She is working as a doctor. She's an anesthetist, and she's working in the neurosurgical theater. Both my sisters are professors, one medicine, one anesthesia. My wife is professor of ophthalmology as well. So as you can see that there is discrepancy, there is clear discrepancy. The incidence in medical students between men and women is 35% to 65%. Women are the majority in some specialty like dermatology, more than 70% in some departments. So women in medicine are majority, whereas women in neurosurgery in Egypt, they are minority. Why? I'm not concerned about the reasons, but I'm concerned about how to encourage medical students, women medical students, in order to love the neurosurgery as specialty. That is our role as organization, as the Egyptian Society of Neurological Surgeons, to support them starting while they are medical students. But I go back to this publication of one of the Egyptian leaders of neurosurgery, which was published in Neurosurgery 2002, Professor Said Igindi, and I'm happy to take this quotation, saying that becoming a neurosurgeon in Egypt is a long, arduous process. Another publication of Professor Peter Black in World Neurosurgery 2020, which is evaluating the training programs in different countries all over the world. This scoring is out of 40, and as you can see that Malaysia is getting the highest score, 21 out of 40. I think Sharon would be happy when she knows such information. And Egypt is taking 18 out of 40 points. And then I have important publication in Neurosurgical Focus, which was critically evaluating the process of neurosurgical education in Egypt and Africa. We have two types of certificates. In Egypt, as you can see, the training programs extend up to 9 years. This might be a reason that we have few number of women in neurosurgery. They like to take easier specialties and lesser period of training programs. And it is important to note that in some countries like Algeria, their training program is only 4 years. That's why they have plenty of women in neurosurgery. Again, I would like to thank Professor Yuko Kato on behalf of CANS, not on behalf of the Egyptian Society, because I think everybody in the Africa neurosurgeons, the young neurosurgeons, African especially, they are grateful to Professor Yuko Kato for the great effort she's doing in the process of education and training and for supporting neurosurgery in Africa. She is honorary president of the Continental Association of African Neurosurgical Societies. This is photo of the chairman of our Egyptian women in group in neurosurgery with Professor Yuko Kato in one of the meetings. We go back to our webinar today. We have registrants over Zoom to 212 right now. Until yesterday, we have 212 registrants, and we are doing a live broadcast over the neurosurgical TV of John Bennett, I would like to thank him. And we are doing a live broadcast over the CANS page over the Facebook. And we have a lot of attendees listening to this activity. This event is recognized by the World Federation of Neurosurgical Societies with the approvals, and these certificates we are offering to all attendees. They can print it electronically after the meeting, and this is the link you have to put in the browser. The username is the email by which you register to this Congress, and this is the password. And you can print your certificate electronically after the meeting. Just allow a few days in order to upload the emails to our system. I would like also to announce that next Friday, we have another World Federation Neurosurgical Societies event, which is going to be organized with the Cerebrovascular Committee of the WFNS, Professor Talat Kris and all colleagues, and it's going to be held at our regular time of our webinar series, 2 p.m. Egypt time, 12 p.m. GMT. Also, an important announcement that we have an important meeting I'm organizing in Egypt in October, the third Demands Congress Mediterranean Association of Neurosurgical Societies. Hopefully, if the pandemic is finished, otherwise it's going to be postponed to next year. All of you are invited, and I think it would be a good opportunity to visit the Grand Egyptian Museum. Thank you very much for attendance, and thanks to all of you. I think Sharon is going to introduce our first speaker, and it's time to start our scientific sessions.
Okay. Thank you, Prof. Nasir. So our first speaker today is Professor Federico Di Rocco. And Professor Federico today will be speaking on past, present, and future direction of pediatric neurosurgery. I think that's a very important topic. See, there's a recent interest in a lot of neurosurgeons in pediatric neurosurgery. So I'd like to welcome Professor Federico.
Thank you very much. I will try to see if you can see my screen. Just a second. Oh. Wait, this is not the right screen. Here we go. You should be able to see my screen. So I would like to thank the organizers. Thank you very much to all of you, to Professor Cato, Professor El-Ghandour. It's always a great pleasure and honor to be with you. I'm proud to represent and to start this first discussion and meeting with this very specific topic of pediatric neurosurgery. I think it's a very ambitious program that you draw for us, because discussing about the future and the history is always very interesting and also very challenging. The story of pediatric neurosurgery started as the story of neurosurgery in the prehistoric times. We know there have been surgeries, practices in people, in adults and children at the beginning of the story of the neurosurgery. And at the beginning, neurosurgery started as a general surgical specialty. So there were general pediatric surgeons doing the neurosurgical procedures like in a meningococcele. They would treat hydrocephalus, infection, brain tumors with limited knowledge, limited techniques. And this is the prehistoric times, as we could say, of the pediatric neurosurgery. Then we started with the modern era of neurosurgery with persons like Cushin Denning or Oliver Corona in Europe. And very early, we had the beginning of neurosurgery, also the beginning of pediatric neurosurgery. And the people started to do surgery also in children, like Cushin did. And we have all these first reports of his great experience also in children. And since the beginning, there was the problem of the relationship between adults and pediatric activities, because children would have been taken care of in pediatric hospitals but the surgery would be done in neurosurgical or general neurosurgical wards. And so we would have this problem of transferring children from one center to another for their pre-op and post-op care in the pediatric hospital and the surgery in the general neurosurgical ward. We were at the beginning of the story of the neurosurgery. The exploration were very limited. We had the retinogram, we have the problem of hemostasis, we have the problem of magnification, like we had, of course, in adults. But pediatric neurosurgery was already started, and we started to understand that there were specific disease and specific physiopathology that needed to have innovating new approaches. And then this is where the pediatric neurosurgery developed, not anymore as a specialty of the pediatric surgery, but as a real neurosurgical activity. So it would be neurosurgeon dedicated to treat children. And this was recognized with Ingram, who started to do the pediatric neurosurgery. And this is also the same, not only in the United States, but also in Russia and then URSS, in which the specificity of the pediatric field were discovered very early. As we said, we had people really started to be neurosurgeons specialized in children, and they developed this pediatric neurosurgery activity. And so from a general neurosurgical approach, we started to have neurosurgical approaches dedicated to children. And so again, we had the problem of which model to follow: the neurosurgical hospital, general hospital, with one person dedicated to the children. But the problem was that anesthetist nurses will not be specifically trained to treat children, or developed pediatric hospital, which would be a surgical unit with people dedicated to neurosurgery. So at that point, the people will know, nurses, other specialists, how to deal with children, but the general aspect of surgery could be ignored. And so in most of the centers, there is this possible dual model that are followed, with these things as started in the early beginning of the 19th century, the 20th century, with the movements of children from the pediatric hospital to the adult neurosurgical operating room, and then going back to the pediatric ward, where the pediatric department started. And this was the case in US, in Western Europe, URSS, as we said, but also Asia and South America. So some example, after Ingram, we have Donald Metz in the United States. At the same time, in Russia, after the war, we had Professor Arendt, who started the children in the women's department. So you see again that there was already an important part of women in neurosurgery from the beginning, especially in Russia, as you can see from this picture that was given me by Professor Gorelishev from Moscow. You see that at the beginning, the proportion of ladies involved in neurosurgery in the pediatric field was very high. And this is also the case in which they had also leading position, like the Professor Rostovskaya and Artarian and Mareva Gorolisheva, a lot of women involved in neurosurgery. And you see that in the most important neurosurgical people in the beginning, after the war, 10 neurosurgeon ladies were recognized. During the same time, South America also developed, and North America with Carrea in Argentina, as centers dedicated to pediatric neurosurgery, really pediatric neurosurgical departments, the same in Canada. And as we said, they developed two main models around the Western countries: the neurosurgical general hospital with some neurosurgeons dedicated to children, then increase in really pediatric units in the general hospital with 1 or 7 neurosurgeons dedicated to children. And the other model would be the pediatric hospital, in which there would be a neurosurgical unit with 7 neurosurgeons dedicated to children. And these are the two main models developed after the war, Second World War, that still are used today in the different fields of pediatric neurosurgery around the different countries. After that, there was the beginning of the recognition of pediatric neurosurgery with this first department, the first hospitals, and development also of the international societies. One of the first, the European Society developed in the 60s with the international meeting held in France, for example, And then the same in North America with the American Association, with the International Society that was founded is in some years later with people coming from all the different countries dedicated to pediatric neurosurgery. And you see that since then, it's been around all the world. And as it was already mentioned before, few women still are represented in the pediatric neurosurgery. You see, Mami Yamasaki organized the meeting in Kobe, and we all regret her, of course, and different also presidents. And we have so far just Professor Zuccar from Argentina, who represents women in pediatric neurosurgery. As you see, the pediatric neurosurgery was mostly white men in the beginning of the story in North America. And then also pediatric neurosurgery sessions started in all around Europe, in France, in Spain, but also in Japan, Korea, Australia, Vietnam. And you see that the difference that you can find in societies is also represented in the different societies. This is an example of the more recent Brazilian Society of Pediatric Neurosurgery, in which you see that as women are better represented. We have Nelson Zanon, who has been president, and we have also Simone Ruggiero organized one of the meetings in the last years. And then the Asian Australasian Society, which is even more recent, and you see here that women start to be much more represented in these type of societies. So we have this recognition of pediatric neurosurgery that developed, but also the place of women in neurosurgery that changed during time. What about the specific training programs? They've started all in the 70s and developed even earlier. In the 80s, started a European course, which different cycles, so that are continue every year. So you're, of course, welcome to register to one of the courses of the European Society. This year it will be virtual, of course. But next year will be physical in Italy. And then ISPN also developed courses all around the world in the so-called pre-COVID era when we could actually meet. The World Neurosurgery also recognized the role of pediatric neurosurgery, of the specialty, with officers coming from the pediatric neurosurgery, with the scientific program, which was enriched at courses and in the congresses, and with new Pediatric Neurosurgical Committee, which is chaired by Nelson Zanon, a female neurosurgeon that everybody knows from Brazil. So the important role, and this is the Pediatric Neurosurgery Committee website, and I invite you to go and see it and to connect with the World Federation. So now we are in the post-COVID era, and from this point of view, we are all seeing the blossom of webinars. Every society has developed several of them, so there is will probably be a period of transition when things will settle, but nowadays there are a lot of webinars, and the Pediatric Neurosurgical Committee also has its own webinar series. And what we want also to tell you and to all the different participants and assistants to this webinar is that you can contact at this email address the committee, and we can organize with you a specific webinar in pediatric neurosurgery if you want one in your own country or team. So what are the future challenges nowadays of pediatric neurosurgery? We have seen that it has been developed. It has been developed with different models, but there are still some challenges. One of the main challenges is the interaction with other pediatric specialties. We need to deal with orthopedists, with maxillofacial surgeons, with ENT, and there is sometimes some kind of concurrence with problems with who deals with the spine of children, who deals with the craniosynostosis or some other type of lesions, and interaction, collaboration with these disciplines is essential. And of course, we have to think that there is pediatric neurosurgery with the pediatric neurosurgeons, and we have to deal with the general pediatric surgery and the general pediatric surgeons, because there are a lot of other pediatric specialty that we need to interact with and, in order to develop the activity. So we need to have a good team. And this is especially important if you're working in a general hospital in which you have a pediatric unit, to still be able to contact with maxillofacial, orthopedic surgeons, ophthalmological surgeons, neurologists, endocrinologists that are able to manage children. Then there is also the interaction with the general adult neurosurgeon, especially if you're working in a pediatric hospital, because the adult neurosurgeons are starting to develop hyperspecializations. We have epilepsy surgeons nowadays, we have spine surgeon, vascular neurosurgeon. So there is still the problem of which model to develop. We saw that neurosurgery started from pediatrics and then developed, and so we have pediatric neurosurgery again, which is a mixture of taking care of children and, of course, mastering the neurosurgical techniques. But we have also the fact that we can have adult neurosurgeons that are hyper specialized in one setting, for example, epilepsy surgery, doing that in adults and in children. And so we have this model that we need to also assess and understand which will be the best model for the patient at the end for the future. Because, of course, our neurosurgical activity can also be declined as spinal dystrophy in adults and children, epilepsy surgery in adults and children, and so on. So this is another model that can exist in hyper-specialized centers in which you will have doctors, neurosurgeons that will deal either in the neurosurgical general hospital in the pediatric unit, or in going to the pediatric hospital neurosurgical unit for very specific topics like the vascular, the oncology, craniofacial, and so on. And so in this case, we will have an interaction between the pediatric neurosurgeon with the adult neurosurgeon to develop between the two specialties. And the risk is that if we are going to develop different hospitals separated from the adults, is that we will have two different types of surgery, and this is, of course, not good, neither for the adult, neither for the children. Because, of course, we need to think that our children will become adults at a certain point. Their quality of life has improved. The results and the outcome of pediatric neurosurgery has improved. And so these fetuses that we manage nowadays will become adults, and the transition needs to be analyzed. So we have nowadays the challenge to understand that what we are doing in the fetus surgery, for example, will continue in adult life, and we need to assess this not only from the surgical point of view, but in the global perspective for the patient in his quality of life. And so we will have to also develop interaction with the adult neurosurgeon to tell them what to do when they will see our patient who had been operated on for epilepsy, who had been treated for a tumor, who had a craniosynostosis, a cyst, a malformation, who had a problem of meningoencephalocele, and now they are 30, 40, 50 years of age. And so again, the challenge for the future of pediatric neurosurgery is to be able to develop this interaction for the sake of the patient. Of course, this hyper-specialization raises, as I said, these main problems of which model to follow, which model is the best for the future of the pediatric neurosurgery and of the neurosurgery in general. And this is still very controversial. We asked with a survey to the European neurosurgeons what they would think would be the best model for the future of the transition, what is done in your institution. And as you can see in the slides, there are so many combinations that are done in the different centers around the world, which means that still we have not found the ideal model. And what we see, which is the model, you have several examples that are used. And when we ask them, what do you think more appropriate for the patient? You see, again, a lot of models that are discussed, but in most of the cases, what we want is a mixed surgical team to treat with the adult patient that had pediatric pathology. So again, the importance of this interaction, cooperation between the adults and the pediatric neurosurgery, and this is something that will really be the challenge for the next generation of neurosurgeons to develop. This problem of the model is associated with the problem of hyperspecialization, and is a high-income country issue. We have to remember that the situation is completely different in other countries. where we have neurosurgeons that are dedicated to adults and children with limited resources. And of course, the problem is completely different. And this is where the children are in developing countries, because of course, the pyramid of the ages is completely different, with much higher numbers of young patients and children in these countries. And so, as Professor Schutz used to say, we need to think which is the best model for developing countries, probably different from that of the Western countries or Japan. We need to think different models for different times and different problems and problematics. Of course, in sub-Saharan Africa, the challenges are completely different than that of Egypt or North Africa or Europe. And we also know that in Europe, the demography is completely changing. Some things will also change due to the modification of the demography and children in Western countries. So we have different challenges. For some countries, it will be to develop the specificity of a general neurosurgeon to understand what is important when dealing with children. And in countries in which the pediatric neurosurgery is already developed and recognized, to maintain its distinctive features from the adult neurosurgery. Because of course, we know that pediatric neurosurgery is different, but we still need to understand and go deeper in the specificities of this field. We know, for example, starting from the basics, your relationship with the families and the parents is different. In an adult setting, you have to deal with the patient who has a disease. You have to explain the pathology. But in children, this is different. The pathology are different. The physiology is different. And you have to deal with the parents with a different type of relationship. And this is something that is, of course, very important when you're dealing with children compared to older patients. Parental reactions are quite common. You have the culpability of the parents, depression, the social professional consequence, the higher stress that you have during the child growth related to the diagnosis, to the surgery, when every time they come to see you. So this is very important that you consider this specific aspect and that you're familiar with this when dealing with children. Of course, from the medical point of view, we all know that the physiology is different, the anatomy is different. Just stupid and simple examples. The frontal sinus will not be there in the newborns, but also you see that neonates and newborns, they will have different anatomies at the level of the ethmoid sinus. Even worse, there will be no real bone in the skull base. So all the techniques should be adapted, and you should master all the different techniques and know that there are specific aspects. And this is even true for the pathology. We all know now that there are subgroups of medulloblastoma that change according also to age. Some of them will be seen in adults, others will be seen in very young ones. So the pathology are different, so the answers are different, and the technique also should be different. This is true for the medulloblastoma, it's true for all tumors, it's true also for other type of malformation. This is for the cavernous malformation. There are predisposition, there are genes, and the pathology are different also from the vascular point of view. So we really need to understand the specificity and to continue to study the specificity of pediatric neurosurgery. And of course, one of the other future challenges, as we said, is to have a better representation of women in neurosurgery, also in pediatric neurosurgery. We have seen that we have a high rate of women doctors, but of course, is something we have to celebrate and congratulate. We have a higher rate of women neurosurgeon, and we have a higher rate of women in pediatric neurosurgery. This is just to show you that in the courses from the pediatric neurosurgery in Europe, you see that there is quite the same number of women and men, and which is, of course, something that we are happy with. So for the future, we have to understand how to continue the research in the physiopathology, in the genetics, and the pedigenetic mechanism, the normal growth of the children. We have also development of new tools, and this is the problem because children are, the diseases are much rarer than in adults, so there is less resources, but we have a lot of different models that we can develop to better understand and treat our patient. We have the help of animal models. We know better the physiology of the growth of the posterior fossa, how things go from the skull base, how the foramen magnum will grow in different syndromes. We have new fields in pediatric neurosurgery We have the antenatal fields that is developing excessively rapidly, with possibility of develop new surgical approaches, new techniques. For example, as I said, the antenatal surgery, in which we do the surgery in utero. We have new techniques outwards in craniofacial surgery, for example. But we will have also very soon also new therapeutic approaches. We have them in, for example, in mucopolysaccharidosis, in which we started to treat patients with enzyme therapy. We have gene therapy for some incurable disease, in which we can treat them by specific stereotactic injection. And this is already done currently in the present. We have also treatment for the tumors that are developed with inhibitors and of the different pathway. So the challenge will be for the neurosurgeon and for the pediatric neurosurgeon dealing with this pathology to be able to use this technique, to know this technique in order to be independent from what is done, and to not to lose the field of research and interest to the oncologist or the pharmacologist or the neurologist, for example. And this is also true for the malformation. We know now that we have inhibitors of, for example, tyrosine kinase that can improve the results in the animal models, but it's not only the animal models. We started to use the treatment already in humans. So we have the possibility of new genetic-based therapy that will change probably the future of pediatric neurosurgery. And it's not only the future, it's already present for some of these pathologies. So we are now in the after recognition era. We have seen from the very beginning was the fight for the recognition of pediatric neurosurgery. Now this pediatric neurosurgery exists. We have dedicated staff, dedicated wards, other department, hospital, units. We have dedicated teaching. We have dedicated meeting, dedicated societies, but we still have some question for the future. We still need to develop the good model for low-income countries, in which we have to be very rational in the development of different models. We have to develop a good model for the high-income countries, so with different challenges, and also with restriction in the money issue, because also in high-income countries there is a restriction in the budget of the hospital, so we will have faced the same problem very early, and also some aspects in the certification. Who will deal with children? Do we need to have specific formation, specific certification to deal with children? The main issue will still remain the same as all the fields of neurosurgery, is that we are still evolving new techniques, new approaches, but our knowledge of the diseases is at the end very limited. And I wanted to finish with this famous slide from the Dandy works more than 100 years ago on the experimental anencephaly, and still we're using the same obstruction or communicating definition that Dandy used. We know it's very limited, but in 100 years of evolution, we are not much in a better, our knowledge has improved as good as we would hope. So I thank you for listening, and if there are questions, I'm very welcome to answer. Thank you.
Thank you very much, Professor Federico, from this very and I would like to ask Sharon if there are any questions in the panel.
Okay, thank you very much, Prof. Federico. A very motivating talk, clearly looking into the future and how we can integrate the neurosurgical field with general neurosurgeons and pediatric neurosurgeons. I think that is one of the issues in the developing countries, how they can integrate both general neurosurgery and pediatric neurosurgery. So is there any questions from the panel for Prof. Federico?
Federico, thank you very much for a nice presentation as always. So just I want to ask, because your presentation was very, very precise and also encouraging one. What about the situation about the prenatal the treatment, prenatal, the pediatric advancement? Just let us know, please. Thank you.
Prenatal is exactly the example. The Western countries have the same problems like everywhere, which are the numbers of centers that you should develop in each country. So we know nowadays that for some strict indication, prenatal surgery has a role, but we also know that you need a very specialized team, not only neurosurgeons, but also gynecologists, anesthesiologists dealing with this type of problems. And we know that the numbers of patients is really limited because the indications are very limited, and then they change according to the country. And this is where it really depends on the different models that each state can afford. In some countries, for example, they decided that they prefer the patient to go to centers where it is done than develop their own center, because it would be easier and cheaper to make the family travel rather than organize everything in their own country. So this is, and other countries like Japan deserves to have 1 or 2 centers, but then you have to think how many centers do we really need. For example, France has decided to have just 1 center in Hôpital Trousseau, where the gynecologists leading the project are, and the surgeons will move with the family to this center. So, because it will be cheaper than organizing 10 centers around France, where they would do only 1 case per year. Instead, we focus 10 patients in the same center where everybody's got the experience. So, pediatric neurosurgery is definitely something that will needs to be involved in the fetal surgery, but fetal surgery also stresses the fact that in some countries, the neurosurgeon is only a spectator or an advisor, or sometimes even absent. And again, it's a general surgeon or gynecologist doing the procedures. And this is something that is not good for the patient. So pediatric neurosurgeons in general and pediatric neurosurgeon needs to be cautious on the fact that pediatric neurosurgery is an attractive specialty, and we have the problem in all the fields. We have interventional neuroradiologists who want to deal with the vascular aspect of the neurosurgery, and the young neurosurgeon will have less and less cases to train. We have endocrinologists who will have started doing therapies, bromocriptine and others for the hypophyseal adenomas. We have the intensive care people who wants to treat the trauma. We have orthopedics who want to treat the spine, and so on. So we need to decide which is the real model we want to follow, because if we don't do that, we might end up like the cardiologist, cardiosurgeon. Cardiac surgeons, at least in France, they are in their small world. The cardiologist sees the patient, he decides, oh, we need to change the valve. He sent to the surgery, the valve is changed, the patient go back to the cardiologist. The surgeon doesn't know the patient, doesn't know the follow-up, has no return, and is just there to do the manual work. Neurosurgery, the appealing part is that we treat the patient, and in pediatric neurosurgery, we treat all the family. So we need to think a larger specialty in which we should be able to deal with the pathology completely, and not only the mechanical surgical part. But the problem is that all the fields are starting to become attacked by other specialties. The oncologists will call us and saying, you need to do the surgery because my therapy failed. No, I want to be in the discussion from the beginning, should I do surgery or a medical treatment? And this is the same for fetal neurosurgery. So we really need to be able to remain in our strong position, leading the discussion in all the pathology. Because what I said for the oncology is the same for the craniofacial and the maxillofacial surgeons, for DNT, for the spine. In all the fields, we have collaboration that can become also an aggression to our field.
Thank you.
Thank you very much. I don't know if there are any other comments before we proceed to our next speaker.
I think we can proceed, Prof.
Thank you very much.
Thank you very much.
Thank you, Federico.
Now it's time to move to our next speaker. It gives me great honor to introduce one of the African leaders in neurosurgery, Professor Samuel Goblin. And actually, Professor Samuel, he is honorary president of the Nigerian Academy of Neurological Surgery. He is honorary president of the African Federation of Neurosurgical Societies, and he's honorary president of the Continental Association of African Neurosurgical Societies as well. Nobody can ever forget his activities in organizing neurosurgical meetings, educating and training many Nigerian and African neurosurgeons. And he's going to speak today about historical and scientific reasons for incorporating women in neurosurgery. Thank you very much, Samuel, for giving us such honor and for contributing to this important event. Samuel,
thank you very much.
Thank you.
It's unmuted. Can you hear me?
So, yes, now it's good. Yes.
All right. Thank you very much, Nasser. I would say indefatigable Nasser. You are wonderful.
Thank you.
It is indeed a pleasure to be invited to give this address. And in the course of my discussion, you see why it is particularly a pleasure. Yeah, sorry. Yeah. Yeah, are you all right? Just share the screen. All right. Can you see my screen?
Yes, it's very good.
Can you see my screen?
Yes, Samuel,
Right.
it's very good.
This is nostalgic picture was taken at the Cannes conference, and I'm just showing it to
Samuel, please,
emphasize,
would you maximize your screen, please, and start the show?
Yeah.
Just maximize from the bottom
Yes.
to start the show, the PowerPoint show. Yes,
That's
that's
all right.
good. Perfect. Thank you very much.
All right. Yeah, Yoko was fantastic. She gave us incredible assistance at the Cannes meeting in Abuja in 2018. Thank you very much, Yoko. I'm happy to see you again in the forefront of this sort of exercise. The topic given to me is very interesting. In fact, I had wanted to talk on something else, but I was navigated to this topic, and I'm happy to address it. Religion and science have different views on the human race and how it came into existence. Both of them recognize the necessity of having males and females. I think we all agree. And no society can in fact survive without the sexes. Also, for advancement of knowledge, wealth, polity, and health, both sexes are very, very important. Also, let me say, since we're dealing with neurosurgery, brain is the master of the body. Evolutionary, the evolution reaches perfection in the human brain, as we can recognize that it distinguishes humans from all other species of nature. It is no wonder it is positioned where it is, at the highest point in the human body, and protected with the fortress of the skull. It was impenetrable for a long period of human history. And philosophers could never understand what the brain did. So they assigned the functions of the heart and so on to it. And those who attempted to defy that fortress of the brain paid for it heavily. And this continued until modern neurosurgery came into existence. The Egyptian physiologist who was my teacher, Professor Talat, he posited that surgery reached its zenith of development when surgeons had the courage to operate on the human brain. Women in neurosurgery are very few. And this is probably one of the reasons we are addressing this topic. The society was founded to also address this issue. and to address make sure that gender equity is restored. This will typify what is happening globally. Example from the United States shows that even though women constitute almost 50% of the medical graduates, in neurosurgery, only 12% are women. And of those who are practicing, only 5% are women in the United States. In the general population, women are quite populous, and in fact, in some countries and societies, they are more in number. And some of the medical specialties like ophthalmology, anesthesia, pediatrics have good representation of women, but not the surgical specialties. Why then are there few women in neurosurgery? Because we have to make a diagnosis in order to offer some treatment. Let us examine the situation further. Is neurosurgery difficult? There has always been that perception that neurosurgery is a difficult specialty. Preclinical years in the medical school, most students shy away from neuroanatomy, neurophysiology, and neuropathology, the neurosciences. But some women are very brave. They confront these difficult areas and exceed and succeed. And in fact, do better than their male colleagues. Is it physical strength that is the deterrent? Neurosurgery needed considerable physical strength to do craniotomy, spine surgery, etc. And these were time-consuming. The days of borehole with a jigsaw saw to turn the bone flap. However, things have changed. Technology has brought in innovations that make these processes very, very simple and effortless. So physical strength is no longer important in practicing neurosurgery. Is it family demand? This may be a possible deterrent considering the career in neurosurgery. It's very difficult to combine family obligations with a neurosurgical practice. How do you look after your home and your children and get involved in the heavy duties of neurosurgical practice? Personal experience. When I finished my training and returned to Nigeria to start a neurosurgical service, I was alone in the unit for several years. And during that period, I had to be on call 24/7. I don't know how a married woman with children could have coped with that sort of stress. Let's go back to history. We know that neurosurgery was started by the school of Habikushi, Walter Dandy, and William Huxley. Habikushi was the father of that school. Hugh Kearns, Norman Dott, and Kenneth Mackenzie from different countries trained under Habikushi and returned to their respective countries to spread the gospel in other societies. It is evident that the pioneers of neurosurgery were males, but male domination has continued, though not necessarily deliberate or due to gender discrimination. And say so because Diana Beck, who started neurosurgery in the UK and was in fact reported to be the first female neurosurgeon globally. She trained under Hugh Kearns, who, as I said earlier, trained under Habikushi. So there was an opening, and they took advantage of that opening. Over the years, more females have entered into neurosurgery. Ruth Kerr Jacoby and Karen Marasco in the US. In Asia, we hear of Kanaka. And the following slides will show the unacceptable situation that exists at the moment. Some of the statistics may not be accurate because surprisingly, the figures are changing every day. Medical school graduates constitute about 49%. But neurosurgery residents are only 12%, as I said earlier. In West Africa, women are so few in neurosurgery, unfortunately. And according to a recent publication by Claire, there are only 243 women in neurosurgery in the whole of Africa. Algeria makes us proud by their wonderful contribution in this sphere. The women, as we are told, number up to 35% of Algerian neurosurgeons, and in fact account for 56% of African women in neurosurgery. This is extraordinary. And we must recognize the mentorship of our colleagues, Professor Faiza Lalam and Professor Swat Bakhti. They are obviously played a major role in achieving this wonderful result. Morocco comes a distant second, I would say, because they have only 25 females in neurosurgery, according to the figure available to us. The numbers may have increased by now. And again, untiring Nadia must be congratulated for the role she's playing to push the advancement of women in neurosurgery, not only in Morocco, but also in Africa and internationally. South Africa has 18 female neurosurgeons, and Perez and Marare are to be congratulated for their efforts. Egypt, which has the highest number of neurosurgeons in Africa, I'm told about 500, it could be more. I was, in fact, before this lecture, was told there were only 3 women in neurosurgery in Egypt. But from the introductory remarks, it's obvious that the number has escalated, many more. And I'm happy to hear that, because I expect Egypt to be in the forefront of the number of women in neurosurgery. In my days as undergraduate in Cairo University, I know in my class there were almost more women than men. So where did they go to after? West Africa has only 14 women in neurosurgery, with Senegal, Nigeria, and Ivory Coast having most of them. Most of the countries in West Africa have no neurosurgeons, female neurosurgeons. Yes, in Central Africa, the figures are also poor. How then do we achieve gender equity? We must recruit more women in neurosurgery. We must avoid gender discrimination in offering opportunity for trainees. And we must afford recognition to women who have already gone into the profession and are practicing. When it comes to election of officers and other things, we must recognize them and give them appropriate positions. I'm going to address mostly the scientific reasons for recruiting women into neurosurgery. These attributes have been emphasized by different people as very necessary for entry into neurosurgical practice: intellect, meticulousness, perseverance, dexterity, competence, attitude and empathy, and of course the brain. History has proven unequivocally that women are as good as men, and sometimes better in intellect. Let's recall Nobel Prize winners in the past. Maria Curie, who won the Nobel Prize in Physics in 1903, and in fact followed it up with Nobel Prize in Chemistry in 1911. Also, the Nobel Prize in Chemistry in 2020 was shared by two females, Manuela and Jennifer. Evidently, women have intellectual capacity to do anything. Admission to medical schools is very competitive, but in most countries, women have shown that they are equal to that competition. Neurosurgery should intensify efforts to recruit more women into the specialty. Another attribute is being meticulous. Women are more meticulous than men most of the time. This exceptional attribute ensures thoroughness and carefulness in performing neurosurgical operations. And this enables us to achieve excellent results. Perseverance is also very important in neurosurgical practice. And women are known to have this advantage over men. They can persevere. They can sometimes even be obstinate. Women possess these characteristics. Dexterity is mostly acquired through training and practice. Women are suited for these skills to be acquired. So, and they're useful for many aspects of neurosurgery like neuroendoscopy, microsurgical procedures, minimally invasive procedures, etc. Pediatric neurosurgery, and functional neurosurgery appears to be attracting more women, which is understandable. So we should encourage this. Women will be patient enough to have excellent history-taking ability and patient examination and assessment. Then, what about attitude and empathy? These are found in abundance in women. And these are essential ingredients for a neurosurgeon. Because challenges of neurosurgical practice, empathy is very, very necessary. However, one must balance between empathy and other considerations. Women are also strong in position to achieve these and that will make them excellent neurosurgeons. There has been a long-standing controversy about the differences in sex and the brain between the sexes. One of the pioneers in this area insisted that women had smaller sized brain than men, and that's where he thinks they shouldn't be as intelligent as men. Amazingly, when he died and the postmortem was carried out, it was found that his brain weighed less than the average size of a woman's brain. So that refuted his theory. But in modern times, more studies have been done on this, as published in the Neuroscience Research Journal. Some of the findings are summarized in this, that the hippocampus, which is critical to learning and memorization, is larger in women than men. Amygdala, that is associated with emotions and their recollection, is larger in men. And incidentally, the two hemispheres of women are better wired than that of men. So they talk to each other better, making the corpus callosum bigger in women than men. These attributes, which are also mentioned here, are additional to acquiring neurosurgical skill or contemplating a career in neurosurgery. Critical thinking, excellent eye-hand coordination, confidence, but with caution, excellent communication skill, stamina to withstand long operations, and effective stress management, which is always the case in neurosurgery. Women definitely are not inferior to men in these attributes. And this is illustrated by the fact that in the political arena, we have had famous women who have ruled their countries very amazingly well. Margaret Thatcher in the United Kingdom, Angela Merkel, who is still the Chancellor of Germany and the first woman to be so elected, Goblin, who ruled Israel, Indira Gandhi, who was fantastic in India. Family demands and other female peculiarities did not prevent them from performing extraordinarily well in their field. And these are just few of the numerous women all over the world who have excelled. So, where do we go from there? I must congratulate the women in neurosurgery. There's a publication I came across which they produced, and they named it Heart of a Lion, Hands of a Woman, what neurosurgeons do. I was surprised. Here we are, talking of brain and neurosurgery. So why didn't we call this book Brain of a Lion, Hands of a Woman, Women Neurosurgeons, what women neurosurgeons do? To emphasize that the brain is the center of human body. In conclusion, history teaches us that women can outshine men in any profession, including neurosurgery, despite fulfilling their other gender-dictated obligations. Science also tells us that women, although different in many respects, most of the attributes that are peculiar to their sex are advantageous and could make them excellent neurosurgeons. It therefore means that more effort should be invested through mentoring, as has happened in many countries, to recruit female neurosurgeons, female doctors to be trained as neurosurgeons, in order to bridge the gap that already exists at the moment. I must say that progress has been made in recent years, which makes it difficult to keep track of the statistics. But the journey is indeed a long one, but at least we have taken some steps, as it should be the case. So we're very optimistic that the gender gap will gradually be closed. Coming personally, in my center, Memphis Hospital for Neurosurgery at Enugu, which only was started in 2002, we started neurosurgical training about 2015, and we have only been able to produce one female neurosurgeon. And Linda, that female neurosurgeon is Linda, as you see in that this lady here. That year, 3 of them from our center were certified by the West African College of Surgeons, and we're happy with Linda. And Linda, indeed, is the second female neurosurgeon in Nigeria. She was second. Distinguished ladies and gentlemen, let us persevere and help to bridge the gender gap in neurosurgery. Thank you very much.
Thank you very much, Professor Samuel, for this great talk. Actually, we are learning from your experience, and thank you very much for collaborating to this important event. I now ask if there are some questions or comments from the panel, either in the Q&A or the panelists. Sharon, do you have any questions?
Yes, thank you very much, Professor Samuel. I believe when it comes out, when a man says it, it makes more sense. If I had presented something like what you presented, people would say that I'm being biased. But I really thank you very much, because you are actually mirroring everything a woman neurosurgeon feels when she works in this field. And you've said something very true. And thank you so much. That's all I'd like to say. Thank you so much.
Thank you very much. Sharon, any other comments? Okay, thank you, Professor Samuel, very much for this great talk. And I think, Sharon, it's time to move to our next speaker. Would you introduce Rida from Jordan, please?
Yes, it gives me very great pleasure to introduce Dr. Rida Kataiba. She's actually very active in a lot of our webinars, a very up and coming young woman neurosurgeon which gives me great pleasure to introduce. Today she'll be giving us a talk on surgical principles of AVM resection. So the floor is yours now, Reda.
Thank you, Dr. Sharon. It's my sincere gratitude for all your professors and colleagues to be a speaker in this insightful webinar for today, and to be an active member in the ACNS with the support of the Prof. Hugo Cato. And actually, my webinar for today is going to be my talk today will be for, can you see my screen, Dr. Sharon?
Yes, we can see your screen.
Yes, okay. So my talk today is going to be about the surgical principles of AVM resection. And I would like to start my talk with this very nice statement by the father of neurosurgery, Harvey Cushing, who once said in describing the criticalism and the cruciality of the surgical intervention for the AVM. He said it would be nothing less than foolhardy to attack one of the deep-seated race-most lesions. The surgical history of most of the reported cases shows not only the futility of an operative attack upon one of these angiomas, but the extreme risk of serious cortical damage which it entails. How many less successful attempts made by surgeons less familiar with intracranial procedures have gone unrecorded may be left to the imagination. So with this nice statement by Harvey Cushing, one can see the criticalism and the cruciality of surgical intervention with these highly critical vascular lesions. So by definition, a true AVM can be simply undefined as abnormalities of intracranial vessels in which the arterial and venous systems are connected without an intervening capillary bed, in which this nidus is actually a conglomerate that is intermeshed with dysplastic non-functional brain tissues. Now, is it congenital? Yes, it is congenital in origin. However, there is a frequent growth during childhood, adolescence, and even early adulthood in its vessels, with what's known as vasculogenesis, arteriogenesis, and angiogenesis. So these lesions, arteriovenous malformations, are high-flow, high-pressure cerebrovascular lesions, where we have feeding arteries, draining veins, and dysplastic vascular nidus. Now, the lack of the capillary bed in between the arteries and veins will allow for low resistance, and this will permit for the high-flow arteriovenous shunting. And this chronic high-flow shunt produces secondary structural changes in the feeding and draining vessels, dilatation and wall thickening in what's called the vasculogenesis, arteriogenesis, and angiogenesis. Now, with this reminding and the refreshment of the definition and the pathophysiology of AVM, we can see in imaging how important it is to have both MRI and angiography both together side by side, so we can have a more accurate imagination of the 3D structure of these highly critical vascular lesions. So in this enhancing axial T1 MRI, one can see the enhancing lesions in the left parietal area, which in angiography is shown to be an arteriovenous malformation that has been fed by one of the MCA branches and highly draining with the superficial draining veins draining in superficial in the superior sagittal sinus. Intraoperatively, the gross appearance of the vascular malformations will be like a conglomerate of vessels where we have a feeding arteries, and this is a draining arterialized vein in the superior aspect of the lesion. So in this operation, cortical stimulation was performed because of the eloquent location of these lesions. So what is the natural course for arteriovenous malformations, or briefly said an AVM? We have what's known the risk of bleedings, and there are definitely factors that increase the risk of bleeding for these highly critical lesions. Number one, a previous history of a hemorrhage, a presence of intranodal aneurysms, venous stenosis and stasis, deep venous drainage, single deep venous drainage, deeply seated AVM, and small size AVM. All these are factors that increase the risk of hemorrhage in any arteriovenous malformation. Talking in numbers, what would be the annual risk of a bleeding for each AVM? We found that 2 to 4% is actually the most defined annual risk of a bleeding per year. However, after inhalation hemorrhage, the risk of a bleeding will be 7% in the first 2 years and then down to 3% in the 5 coming years. If one can imagine or calculate what is the cumulative risk of a bleeding once in a lifetime with that equation or assumption that we have an annual risk of a bleeding of 2 to 4% per year, then the cumulative risk of a bleeding once in a lifetime would be in the formula of 105 minus the age of the patient in years. In mortality, after the first hemorrhage can reach up to 10%, and the subsequent hemorrhage, which is the second hemorrhage, can reach up to 40–50%. The annual rate of all patient mortality can reach up to 1%. So talking in numbers, we can see that they are critical vascular lesions, in fact, and very dynamic, that hold a significant risk of morbidity, mortality with each subsequent hemorrhage. So here comes our role as a neurosurgeon. How should we manage these high critical vascular lesions? We have different options as any intervention, no intervention, focused radiosurgery, embolization, microsurgery, or combined therapy. Now, in no intervention, or what has been said as a conservative or medical management, there was the Aruba study that has been criticized twice in its original version and then in the subsequent observation of 5 years, but yet there is a lot of talk about the eligibility of the Aruba study over the unruptured AVM intervention. So my talk today about the microsurgical role for these the highly critical vascular lesions and how the surgical intervention should treat these lesions. Now, before talking about the surgical intervention and what are the principles for surgery, I would like just to highlight the role of embolization in the surgical interventions, with the major goal is to enable and facilitate the surgery. The preoperative reduction of arterial flow, occlusion of the feeders, and management of the perineal aneurysms are the major, most important roles for embolization. However, this preoperative embolization should be guided by the surgeon and the neurosurgeon who intend to excise this AVM and knows exactly where are the deep, inaccessible, deep white matter feeders that need to be occluded. Embolization may be done by different tools, including the coils, particles, and the most commonly used nowadays, the liquids, and the onyx being the top of them. Now, for example, with this for angio-DSA, we can see the posterior fossa AVM here fed by one of the superior cerebral artery, and we can see the feeder or the flow-related pedicular aneurysm arising from this superior cerebral artery that has been occluded by successful preoperative embolization using the onyx. So, coming to the microsurgical treatment, actually in the process of decision making, we should look back to the literature and see what are the studies and their assumptions on surgical intervention for AVM management. For example, the Wang and colleagues said that high arterial input pressure and the venous outflow restrictions are the most predictors for hemorrhage in the AVM. While Spitzer and colleagues insist and emphasize on the size of the AVM and assume that an AVM size more than 3 centimeters with a higher feeding artery pressure have a larger hemorrhage. And that was supplemented by Graf and collaborates who said that the 5-year risk of hemorrhage would be 10% for an AVM size more than 3 centimeters. However, it would be up to 50% for those AVMs that size less than 3 centimeters. So one can see how much the size of AVM can increase the risk of hemorrhage with a smaller AVM rather than the larger AVM. So before embarking to surgery, we should classify each AVM by one, because no two AVMs are alike at all. Each AVM has its special characteristics and special parameters that should be classified, and accordingly we put them on what risk of surgical intervention for that AVM. The initial split and mark grading systems use the 3 parameters of the size, the location, and the ministry of that AVM, and that we have a total score of 5. That was then modified to classify those grades into classes. Grades 1 and 2 would be in Class A, Grade 3 would be Class B, and Grades 4 and 5 would be Class C. Class A would be going for surgical intersection, while Class B would be multimodality, and Class C conservative with high risk for surgical intervention. Furthermore, thanking for the Lawton and Young who classify and put another classification systems for the AVM with different parameters, taking into consideration the patient age, the presentation of the AVM, and the uselessness of the AVM. So he put that 1 point for those younger than 20, 2 points for 20/40, and 3 points for 40. If it was unruptured, which means intact AVM will take 1 point and diffuse will take 1 point. Now combining these two classifications together, we'll have a total score of 10. And the cut-off point for surgical intervention will be a total score of 6. That means those with a total score of 4 and less will have a minimal risk for surgical intervention to that AVM. So once we decide to go for surgical and microsurgical intervention to treat that AVM, we should ask ourselves when to operate and when we have to operate. Actually, a good understanding of how to select the most appropriate treatment is as important as the mere technical skills. And besides considerable experience with all surgical aspects, you should have a good understanding of the indications, efficacy, and complications of other treatment modalities. With ethical responsibility, it is of yours to give an answer seeking patient the clear opinion of what is the best treatment modality for that specific AVM. Now, AVM surgery should always be a selective surgery, an elective and selective surgery. It never be an emergency unless we have a substantial ICH that requires an emergent evacuations in the form of life-saving measure. And put in your mind that most of those new surgical deficits from AVM will improve with time. So coming to the microsurgical intervention and details of the surgery, starting with the positioning and keratomy. Actually, there is no routine positions. It is highly individualized and needs to be tailored according to the lesion and the patient himself or herself. Generally speaking, for convexity lesions, you should always put it in a perpendicular approach. Use the gravity to minimize the brain traction, and the lesion should be in the uppermost point of the surgical field. For keratomy, make it as large as possible, even larger than needed, because you need to map and have a thorough mapping for the superficial and the vascular surface anatomy, especially those of the superficial draining veins. Make it as wide as possible. Make the keratomy as large as possible, just to enable you to have a thorough mapping for that vascular surface anatomy and superficial draining veins specifically. So the larger and the more number of burr holes, the short passive keratome, and that should decrease the risk of injury to the dilated draining veins, which may be traveling within the parasagittal dural leaves and venous links. What about the CSF draining system? Yes, it will help, whether by lumbar drain or by an EVD. It should give you a better control of ICP, especially during the surgical management. There always should be a careful opening the dura because you never need to attempt any injury to those potentially attached veins and superficially draining veins. So following the keratomy, a wide urotomy unveil should be done to unveil the brain while protecting the underlying vessels. And the dura is opened slowly, meticulously, because scarring from previous hemorrhages may cause it to be adherent and attached to the underlying AVM or associated vessels, which, if not studied very well preoperatively, may endure with disastrous bleeding just from the beginning of the surgery. So, in brief, to summarize the major steps for any AVM excision and resection, we can put it in 6 major steps. Number one, you have to understand very well and accurately the 3D structures of the AVM, and that would be done only by combining both MRI images and angiography. Prepare for the surgery, as we said, with a wide cursory. Number three, you have to have the first initial step of the battle, which is judicious identification and then disconnection of the feeding vessels. Then you start the battle with strategic circumferential dissection of the nidus and then careful disconnection of the draining veins after being accurately identified. And finally, you go for insightful excision of the AVM nidus. Now, starting with each step in detail. As said, to understand the three-dimensional structure of the AVM, you have to have both MRI and angiographic images together side by side. You identify the surface landmarks, large draining veins, and embolic material if used. All feeding vessels and their morphology, location, and serpentine routes should be accurately, meticulously identified before starting your surgical excision. Side of the hematoma is accessed first, and then the eloquent brain would be accessed last. Step number two, generous exposure on the preparing of the battle. As said before, you plan for the flexible walking angles, the appropriate patient positioning, and especially the hip positioning. Use of the gravity retraction and wide arachnoid dissection for the more dynamic retraction with the suction device. Plan for proper dissection planes to detect the white matter troublesome feeders. And here coming the first step of the battle. You have to manage the feeding arteries. Actually, it is the first initial critical step in AVM resection. You have to identify, and it is the identification of the feeders. Identification of the feeders is the first important step and the critical step in this battle. And those feeders are of two types, the cortical feeders and the white matter feeders. That cortical feeders actually are of three types. We have those the direct terminal feeder that will go directly to the nidus, supplying the nidus and only the nidus. We have the transient feeders, which will pass through the nidus but never contribute to the to its supply. And we have the third type, which is in-passage feeders, those vessels that will pass through the nidus, partially contribute to its supply, but continue to supply a normal brain tissue eventually. We have to take care that we meticulously, accurately identify those cortical feeders because they are the initial step of our battle. However, here comes the more troublesome vessels, which are the deep white matter feeders that are actually the mere and the core cause of a trouble and disastrous hemorrhage intraoperatively. So to differentiate the draining vein from the feeding artery, which is the most important critical step during AVM resection, dissection, and disconnection, we may use some tricks, and one of them is to apply a temporary clip test. In applying that temporary clip test on a specific vessel, which we don't actually know whether it is an artery and feeder artery or a draining veins, we should look on what's going on the proximal segment of that vessel after application of that temporary clip. So if that proximal segment of the vessels after application of the clip had been tumesced, collapsed distally, and turns blue, this means it is an arterialized vein. But if the proximal segment of the vessel keeps strongly pulsating, it would mean it is a true feeding artery. This is one of the tricks that we can do intraoperatively just to differentiate and help us differentiate and distinguish whether we are dealing with a feeding artery that should be clipped, coagulated, and disconnected, or should be kept to the end of the surgery. Also, we should look at the AVM after application of that clip. So if there was an engorgement of the AVM after we occlude one of the vessels, then definitely that occluded vessel by the clip is an important draining veins. So these two measures is important and actually critical to be applied during surgery to know exactly what is the vessel that we are dealing with. Are we dealing with a feeding artery that should be clipped, coagulated early in the surgery and disconnected, or it is an important draining veins that should be preserved until the end of the surgery and entire dissection of the nidus? So schematic presentations to show you the importance of the troublesome deep white matter feeders of the nidus, and how can we manage or negotiate with them somehow. What we do sometimes is that we need to take and remove a small amount of the white matter immediately around that vessel, so we can catch a small segment of that proximal vessel which have a relatively normal vessel wall that can be readily coagulated and clipped without being thickened, because vessels that are within the nidus usually have a thickened wall that is hard to clip or coagulate. So we need to look for a more proximal segment which is deeper inside the white matter, so we can clip and coagulate more readily. Step number 4, which is now the core of the battle. It is a strategic circumferential dissection of the nidus. And in that, we have 4 major steps, starting with the subarachnoid pale dissection, parenchymal dissection, then ependymal dissection, and then inspection to ensure a complete nidus disconnection. Now, it is the nidus that will be developed, but after the circumferential corticectomy around the AVM, after all superficial feeders have been disconnected. So the first step, which was identification and accurately being sure that we are dealing with a feeding artery that has been clipped, coagulated, and disconnected, and then we start our circumferential corticectomy around the AVM after all superficial feeders have been disconnected. With that, we have to keep in the same plane within the white matter, and that should be within an equal depth of 2.5 to 3 centimeters before proceeding with a deeper dissection. And that would be in a very nice circumferential or spiral configuration of dissection, exposing every aspect of the AVM toward its apex. And as we all know, that the conical shape of AVM always have a base which is toward the cortex and an apex which is deep down toward the ventricles, where the ependymal vessels may contribute to its supply. So we keep that circumferential spiral dissection within the white matter, keeping the same plane of the white matter and within the equal depths. So use the natural fissures and sulci and promote circumferential dissection through these planes. Avoid any uneven planes because this will be a bomb, disastrous hemorrhage that is hard to control. Avoid early, aggressive coagulation of the nidus, and take into considerations the differential of the internal hemodynamics and internal hemoflow, which can easily lead to nidus rupture and brain swelling, which would be very disastrous intraoperatively. So step number 5, which is the last critical step in the battle, which is protecting the dominant vein. As said before, the main draining primary vein should be preserved until the entire nidus is disconnected from all its feeding arteries. With that said, after the AVM disconnection, the veins become and should become darker. As we dissect the nidus from all its feeding arteries accurately, meticulously, this should turn the vein dark. If this doesn't happen, or if clipping or temporary clipping of one of the veins lead to nidus swelling, this means that we are still having a hidden feeding arteries that should be meticulously searched, even if underneath the veins, and coagulated, clipped, disconnected. So we should never start disconnecting the draining veins until we are completely sure that all the feeding vessels to the nidus has been meticulously coagulated, clipped, and disconnected. And if that didn't turn the veins to be dark or cause the nidus to swell, then definitely we are still having a feeding arteries going on alive that should be surged and killed. So, in command operation is a very commonly used term in AVM resection, where sometimes a tear in the main adjoining vein would happen before complete dissection of the nidus. And that's critical situation. Never ever occlude that vein, because if you occlude that vein prematurely, this will lead to more and more problems and disastrous situation. What you should do is just let the vein to bleed, and you use that efficient time to find that feeding arteries. So command operation, when happening in the tear in the main adjoining vein and large feeding arteries are encountered and sacrificed, you should never occlude that vein, just let it bleed, put a tamponade, and use that efficient time to look to that alive feeder that should be disconnected immediately. So this is a nidus schematic presentations where we have disconnect all the important and the primary feeding arteries completely, and then the draining veins should turn dark and blue, and then we are safe to disconnect them, clip them, coagulate them after we are sure that we don't have any more feeding artery giving blood to the nidus. Only then we are able and safe to go to and disconnect the draining veins without any risk for nidus swelling or a premature hemorrhage. This is an example for end passage feeding artery. As you can see, while it passes through the nidus, it will partially contribute to its supply, but eventually it will continue to supply normal brain tissues. Step number 6, which is the last one, it should be an efficient excision of the AVM, where we search for hidden arterial feeders, which is our concern and our nightmares. Any arterial feeder should be completely disconnected, and you look in close proximity or underneath the vein, disconnected completely. After this final step, and only after this final step, we go and remove the nidus. The timely removal of the AVM is the best method to deal with expectedly encountered bleeding from the resection bed. Complete hemostasis is secured only by removal of any residual AVM. Any residual AVM should be meticulously looked for before a complete hemostasis is said to be accomplished. So intraoperative images to apply the 6th step we talked about. We start with the dissection, arachnoidal dissection, where we tear and start grabbing the second arachnoidal layer to unveil the underlying vessels of the AVM. And then we go for parenchymal dissection. We have in this red row highlighted vessels and unquery or unknown or unidentified vessels. We still don't know what is exactly identity of this vessel, whether it is an arterial feeder or it's a draining veins. So we left it and we start with the parenchymal dissection. Deeper inside, we have this in-passage vessel. In-passage vessels, it is a feeder artery that will partially contribute to the supply of the nidus, while continue eventually to supply normal brain tissues. We only coagulate or clip the branches which supply the nidus, leaving the main arterial feeder in situ and intact. Here we have the edges of the nidus and the unknown vessel still left preserved and intact, because we need to cut all the feeder arteries before embarking to disconnect the draining veins. An embolic material was identified in this AVM resections, and this even helped us to further continue with the white matter dissection at the end of the nidus disconnections. Now we can safely coagulate and clip the minor draining veins of the nidus. Another AVM resection, here we apply a microclip, or the surgeons apply the microclip on the terminal direct feeder artery to the nidus. This helps us to coagulate and even decrease the flow to the nidus, because as said, the normal or the arterial feeders of the nidus usually tend to have a thickened wall, which will not be easily to coagulate or even to clip. So we apply a microclips on those terminal feeder, direct feeder for the nidus to facilitate the furthermore coagulations after disconnection of the nidus. So with this AVM lesion intraoperative image, one can easily see how the arterial feeders, arteries, and arterioles have that corkscrew dysmorphic shape, and it's easily distinguished from the normal vessels here, which is an in-passage arterial feeder. So this dysmorphic configuration and corkscrew shape of the vessels and the feeder arteries will help this neurosurgeon to identify the feeders from the normal vessels. And eventually, after you disconnect all the arterial feeder from the nidus and go safely to start disconnecting the draining veins, you should put in your mind that usually we do have a primary and secondary draining veins. The primary draining veins usually are of larger diameter and engorged vessels arterialize the blood inside, while the secondary veins can be disconnected prematurely if and only if you have sufficiently decreased the blood supply to the nidus after disconnecting and dissecting a significant number of the arterial feeders from the nidus. Finally, after the nidus resection and excision from the bed, a complete resection of the malformation should be confirmed by intraoperative angiography, what's called the ICG. It's a must, and should never close until you do this step, where you increase the systolic blood pressure 15-20 millimeter mercury above the baseline and look for any going on alive feeders at the bed of resection at the site of AVM nidus excision. Any feeders should be meticulously coagulated or clipped to cut all the blood supply so that you don't have a post-op disastrous hemorrhage in the patient. All patients should be intubated, sedated for 24 hours, and keep their systolic blood pressure 10-20% below their baseline for continuous 24 hours for complete close observation. With that, I end my talk and happy to having your nice questions. Thank you for nice attention, and welcome to Jordan, to one of the magnificent, insightful tourist sites, Wadi Rum, in the north of Jordan. Thank you for nice attention, and happy to see to listen for your questions.
Thank you so much, Radab. Are there any questions for Radab? Don't see any.
Can I? So thank you very much, Radab. It was a wonderful lecture. Thank you so much. It's maybe the shortage of the time. Just I want to ask the two things. One is, do you use intraoperative image such as ICG? Then it contains a lot of the information for resection of the nidus. And the other one is how you can detect of the eloquent lesions.
Okay.
That is two questions. Next shot, please.
Thank you, Professor Yuka Kato, for the support and the ongoing organization of these insightful webinars. Yes, ICG is an important and a paramount for the AVM resections, and you should never be confident that you did a great job without the intraoperative angiography using the ICG. It should give you a better view of what vessels have been occluded, dissected, and if you still have any ongoing feeders, and you have occluded an in-passage or transient vessel that may put the patient at risk of stroke. And for the second questions, sometimes we may use the electrical cortical stimulations or functional MRI or other procedures, so we can look for the eloquency of the lesion. So functional MRI will do the job. Sometimes if it's not clear enough, we may use the cortical stimulations for the eloquency of that lesions. I think I hope I answered your questions.
Thank you.
Professor.
Thanks so much. Very, very nice presentation. Thank you.
Thank you. Thank you. Thank you for the chance, and always an honor to be an active member in this ACNS Young Neurosurgeon Committee.
Thank you.
My pleasure. And I would send my sincere thankful for Professor Samuel. Thank you, Professor, for the very generous talk about the contribution of women in neurosurgery. That was very nice talk from you, Professor Samuel. And I think it was true enough for what female power and strength can contribute in this field, in this very highly demanding field of surgery.
Thank you so much, Radab. Prof. Nasi.
Thank you, Dr. Sharon.
Yes, Sharon, I suggest just there is one of the attendees who would like to share his experience. His name is Ahmed Hashim. I don't know if he's still joining us. Ahmed, are you here?
I am here, Professor.
Yes, thank you for contribution.
No, actually, I was listening to Professor Samuel in Nigeria talking about neurosurgeons, and I was lucky to share my experience. I was trained by a woman neurosurgeon in UK. I'm an old man now. I did my training in Manchester between 1979 and 1986. I think Professor Yoko knows Caris Bannister, God bless her. Now she is not with us. She died of cancer about 5 years ago, but she was the only woman neurosurgeon in UK in those days, and she was actually decorated by the Queen of England. She was invited to Buckingham Palace, and she was with the only woman chief police officer and the only woman wrestler in UK, and they all got together and was decorated by the Queen for being the only ladies in those days. I think since we have quite few women neurosurgery in UK, unfortunately here in the GCC we have some trainees, but we are waiting for the coming 2 or 3 years to have a fully trained neurosurgeons in the GC in the Gulf area. I think there's one woman neurosurgeon in Iraq where I came from originally. I just want to contribute to the fact that she was my boss and she trained me quite well. We had the ups and downs, but she trained me. All I know now in neurosurgery was attributed to what we did together in those days. And I just want to tell everybody that women is just as good, even better in a lot of areas in neurosurgery, and they can actually help to improve neurosurgery in the future. Thank you.
Thank you. Thank you very much, Ahmed, for these kind words. I think by the comment of Ahmed, now we proceed to our next speaker. May I introduce Professor Kujiro Wada. He's going to speak about bypass surgery. Professor Wada, are you here?
Thank you very much, Professor El-Ghandour, Professor Yoko Kato. I'm very honored to have such a great chance to present my working about bypass surgery. First of all, I will present the bypass practice using a silicone tube. And then I will present the bypass surgery clinical cases, which are the treatment of thrombosed aneurysms of the anterior cerebral artery using bypass. So let's start.
Okay.
My name is Kojiro Wada from the National Defense Medical College. This picture is of the Egyptian embassy in Tokyo. I found it the other day when I was walking around it and took this picture. I hear that there are a lot of great archaeological discoveries going on. I would love to visit Egypt someday. Today, I would like to talk about bypass surgery. I believe basic bypass surgery is superficial temporal artery and middle cerebral artery anastomosis. Before we talk about bypass surgery, let's talk about some basic techniques at dry level. Silicone tube is most convenient to practice. There are a variety of silicone tubes on the market. This photo is the instruments I use in the dry lab practice. At least 2 fine forceps and straight microcaesar are necessary. I usually use tensile nylon thread with 4 mm length 3/8 circle needle. The position of the hands is important. First, remember to use your fingers as if you are writing. Let's talk about the stitches. The needle should pass through the vessel wall perpendicularly. To perform this, the vessel edge should be elevated a little to provide the distortion. In this time, do not grab the vessel edge by forceps, because once internal membrane injured, it can cause blood clot to form. Suture insertion distance should be the same as the wall thickness. The interval of the stitch should be twice the wall thickness. Put 6 to 8 stitches for each side within 20 minutes. Let's talk about dry lab practice. At first, fix the vessel with pin as you see in this slide. The main axis of the vessel should be perpendicular to the operator's right hand. A vessel is usually placed at 1020 on the clock. Prepare another blood vessel as a donor vessel for end-to-side anastomosis. Donor vessel is trimmed in fish mouth, cut 60-degree angle. Then, that side is cut linearly to elongate same length. Arteriostomy of recipient vessel is made by longitudinal linear incision. Place stay suture on both ends and sew 6 to 8 stitches between them. Here is the actual exercise. Place the recipient vessel at 1020. Cut the donor vessel at the 60-degree angle and cut the dull side further into a fish mouth. Place a stay suture on each side. Arteriostomy of recipient vessel is made, and place stay sutures. Start at one end. Manipulate the needle well so that there is no gap in the suture. I did 6 stitches on one side. After suture one side, make sure there is no back stitching, and stitch the other side in the same way. If you have an animal lab, using rat neck and femoral arteries and veins to practice are very useful.
Wait a moment.
Yes, yes, we are waiting.
Thank you very much.
Thank you very much. Take your time, please.
I lost my video.
Anterior cerebral artery partially thrombosed aneurysm is a rare entity. However, high incidence of rupture rate is reported. Direct neck clipping nor coil embolization is usually impossible, so we treat by trapping with reconstruction of anterior cerebral artery. For the reconstruction of anterior cerebral artery, in situ bypass and EC-IC bypass are reported. Sometimes bilateral anterior cerebral artery reconstruction is needed, so in situ bypass is not good enough. Necessarily EC-IC bypass. Furthermore, during manipulation of aneurysm, temporary clipping is needed and result in the infarction. Therefore, we conduct hemi-bonnet insurance bypass from proximal superior superficial temporal artery using radial artery to the distal anterior cerebral artery. I will show you our treatment strategy in the form of a schema. The first step is to deconstruct the anterior cerebral artery on the side where occlusion is expected. In this case, aneurysm exists mainly to left side anterior communicating artery. So, left side anterior cerebral artery will be reconstructed. First, using the radial artery, a bypass surgery is performed with the main trunk of a superficial temporal artery as a donor and the anterior cerebral artery A3 part as the recipient. The left side anterior cerebral artery is trapped. If there is a space to clip the right side anterior communicating artery, clip it, and the thrombus in the neurism is evacuated. If there is no space to clip the right side anterior communicating artery, A3 in situ bypass is performed. Then, trapping of the right anterior cerebral artery is performed. I have experienced 3 cases. I will show you these cases. The first case is 22nd male, admitted by complaint progressive visual acuity disturbance and visual field deficit. CD angiography showed pituitary fossa 35 mm wide, partially thrombosed anterior communicating artery aneurysm. Angiography revealed aneurysm exists mainly left A1-A2 junction. I considered at least left anterior cerebral artery reconstruction is necessary. Superimposition by coronal skin incision was made. Laser interhemispheric approach is performed. I show operation video. To reconstruct the distal blood flow in the left A2, right superficial temporal artery, radial artery, left A3 of anterior cerebral artery bypass was first performed. The bilateral airlines were exposed. The aneurysm was trapped with temporal clips applied to the right side of the anterior communicating artery, left A1 and left A2. The thrombosed blood clot inside the aneurysm was removed as far as possible. The temporary clips were changed to the permanent Sugita clips. In the thinning green, videography showed no residual aneurysm, right anterior cerebral artery patency, and also confirmed bypass patency. Postoperative CT angiogram didn't show residual aneurysm. The left A2 was filled through the conduit from the right superficial temporal artery. Immediately after the operation, the patient's visual acuity and field fully recovered. Postoperative MRI imaging revealed no ischemic complication, and the patient was discharged with modified ranking scale score of 0. 4 years later, MR angiogram confirmed complete obliteration of the aneurysm and bypass patency. Case 2. A 40-year-old man presented with dark headache. CT angiogram demonstrated 2 aneurysms at the left A1-A2 junction. Coronal T2 weighted magnetic resonance imaging suggested that the 2 aneurysms were kissing. The right fisiform aneurysm was considered to be partially thrombosed, so at least right anterior cerebral artery reconstruction is necessary. Superimposition bicoronal skin incision was made. Basal interhemispheric approach is performed. I showed the operation video. In the operation, to secure distal blood flow in the right A2 of anterior cerebral artery, right superficial temporal artery, radial artery to the A3 of right anterior cerebral artery bypass was first performed. Then right aneurysms are trapped at A1 and A2. Kissing part between right and left aneurysm is dissected. The left sacral aneurysm was not thrombosed, with bilateral pericallosal arteries branching from the aneurysm and clipped using 2 Sugita clips at the aneurysm neck. Postoperative CT angiogram didn't show residual aneurysm, and the right callous marginal artery was filled through the conduit from the right superficial temporal artery. Postoperative MR imaging revealed a small ischemic lesion in the right caudate nucleus, but no neurological disorder was detected, and the patient was discharged with modified ranking scale score 0. 5 years later, MR angiogram confirmed complete clipping and trapping with bypass patency. The third case is a 40-year-old woman presented with dull headache. Brain T2 weighted MR imaging revealed a mostly thrombosed aneurysm with parenchymal edema. CT angiogram demonstrated the giant aneurysm at the left A1-A2 junction, so at least left anterior cerebral artery reconstruction is necessary. Superimposition bicoronal skin incision was made. Basal interhemispheric approach is performed. I show the video. To secure the distal blood flow in the left A2 of anterior cerebral artery, left superficial temporal artery through radial artery to the left A3 of the anterior cerebral artery bypass were first performed. The bilateral A1s were identified. 2 right A2 were identified. The right side anterior communicating artery was identified and the Sugita clip was applied to secure right A2 and the left Hoibner artery. Then, the left anterior cerebral artery was temporarily trapped. Opening of the thrombosed dome exposed organized heterogeneous old blood clot, which was aspirated using QSER to debug the dome. The temporary trapped clips of left anterior cerebral artery was changed to permanent clips. Postoperative CT angiogram didn't show any residual aneurysm, and the left A2 was filled through the conduit from the left superficial temporal artery. Postoperative MR imaging revealed no ischemic complication, and the patient was discharged with modified Rankin scale score 0. 1 year later, three-dimensional CT angiogram confirmed complete disappearance of the aneurysm with bypass patency. In summary, we experienced 3 cases of partially thrombosed anterior communicating artery aneurysm. By using the superficial temporal artery as a donor, the anterior cerebral artery A3 as the recipient, and the radial artery as a conduit, we were able to complete the surgery without any new ischemic complications. I explained our strategy of partially thrombosed anterior cerebral artery aneurysm. If only one side of the anterior cerebral artery needs to be reconstructed like schema A, then an L3-A3 in situ bypass would be sufficient. However, it is often reported that bilateral reconstruction of anterior cerebral artery are necessary, like schema B, and if it is determined intraoperatively that bilateral reconstruction is necessary, then the A3-A3 bypass alone is not sufficient, and it takes time to make an EC-IC bypass. So we perform EC-IC bypass first before aneurysm preparation. Here is a summary of the benefits of the superficial temporal artery through radial artery to S3 of the anterior cerebral artery bypass. First, as reported by Arla et al., the superficial temporal artery trunk can provide sufficient blood flow. It also has a certain diameter, so there is less of a size mismatch with the radial artery. Second, the superficial temporal artery has been reported to expand according to the demand for blood flow. Third, the periphery of the superficial temporal artery is not occluded in our operation, thereby preserving blood flow to the scalp and may prevent wound healing trouble. Fourth, the radial artery is an easy vessel to handle because it is relatively tortuous as a conduit. Last, once the EC-IC bypass is completed, there is no need to worry about ischemic complication. We believe that superficial temporal artery through radial artery to A3 of anterior cerebral artery hemiponnet bypass promise a good result for surgical treatment of partially thrombosed anterior cerebral artery aneurysm. Thank you very much for your attention.
Thank you very much.
Thank you very much for this great presentation. I'd like to open our discussion maybe just for a few minutes because we are fine behind our schedule. I think somebody would like to make a discussion. Ghul Rashid, are you here? Can you speak directly? Dr. Ghul Rashid, please unmute your mic and speak if you'd like to say any comments. Okay, now I ask Dr. Sharon to introduce our next speaker so that we can proceed into the scientific session.
Okay, thank you very much, Prof. Nasir. It's a great honor today to have Dr. Anila Dava. She was speaking on gender equity in training and leadership. She's also the co-chair of the ACNS WIN. So I'd like to have Dr. Anila. Are you ready? You're mute, Anila, you're mute. Okay.
Sorry about that. Thank you so much, Sharon, for the introduction. And I also want to thank you, Dr. Professor Yoko Kato, Professor Nasir El-Ghandour, for inviting me to this ACNS seminar. Thank you very much. I also want to say thank you to Dr. Mahmoud Qureshi. I think he probably is not here, but he was the chief guest, and he has been a great mentor and a friend throughout my neurosurgery career and has helped me to become who I am right now. With this, I'm going to start my screen share. So the topic that's given to me today is about gender equity in training and leadership. And I feel that it is time now to talk about it. And in fact, it has been talked internationally, not just in neurosurgery, but in the corporate world, in other sectors of the world. This is the talk in vogue now. Muhammad Ali Jinnah was the founder of Pakistan, where I am from, and he said that no nation can rise to the highest of its glory unless your women are side by side with you. And Aga Khan, Sir Sultan Muhammad Aga Khan, which hospital where I work, the Aga Khan University Hospital, he said that personally, if I had two children and one was a boy and the other was a girl, and if I could afford only to educate one, I would have no hesitation in giving the higher education to the girl. So why equality is important? There has been this big project from the World Economic Forum into 2019, which said that it will take about 170 years to reach gender equality globally and 158 years in North America, which means that it will take about 5 more generations for us to see the gender equality. So although we say a lot of gender equality, we have started seeing it, but the real numbers are we are going to see it 5 generations from now. So why gender equity? Because gender equity is important because if you reduce the gap in women's labor force participation by 25% by the year 2025, you will estimately rise 100 million new jobs for the global economy. And all the data that I'm presenting are data into the World Economic Forum website that I have obtained. So a woman who earns just 75% of what a man with the same level of education and working the same job that he does. Giving women the same access to farming resource as men could increase agriculture output in developing country for up to 4%, lifting more than 100 million people out of hunger. And an IMF study on firms in Europe found that adding 1 more woman to either senior management or a corporate board boosted their return on assets by 18 to 13 basis pointers. And as you know that now a lot of corporates have CEOs as women, The Pepsi CEO is a woman. The Facebook CEO is a woman, Sharon. So there are a lot of corporate world who have also realized on the gender inequality and have taken women on board. In Pakistan, now there's a new rule that for every board, whether it's a corporate board or a medical board, one woman should be a part of that medical or corporate board. Christine Lagarde said that men have an important stake in empowering women. Not only does they help their parents, their daughters, their mothers and sisters to achieve their potential, but it also helps build a stronger society for all. So what can we do about it? So there has been a lot of women leadership development programs. There is FEMA, there is many leadership programs throughout the world by Harvard, by Pittsburgh, and a lot of women who are in academics, who are in education have taken these leadership roles and have taken their academic institution to another level. There are many books that are written in which the women are told that how to be more forward thinking, how to push back, how to lean in, and these are great books if there are any young women in here to increase your leadership skills. So, but still, after all that, not much has changed. If there's only one woman in your candidate pool, there is statistically, there is no chance that she will get the job. Men are promoted at 30% higher rates than women during their early career stages. 90% of the women leave the workforce because of other workplace problems, not just because that she has a child and that's why she cannot work. Women are paid 75% on the dollar of their male colleagues. That drops drastically to 39% if it's the top 2% of the wage earners. And suddenly this is not, I am talking about the corporate world. This is also in the medical field in the US, where a woman and a male at the same academic ranking, a woman would get lesser salary as compared to the men. In a study of 21,900 firms from 91 countries, just over 50% of the firms did not have any female executives, and only 11% of the firms had all female executives. 50% of women in STEM fields will eventually leave because of the hostile work environments. So the world is making progress on advancing gender equality, but there are still nowhere on earth women are equal to men. This is what Melinda Bill Gates said. Here, what keeps me up at night? I imagine waking up one morning to find that the country has moved on, that the media has stopped reporting on systemic inequalities, that diversity remains something companies talk about instead of prioritizing diversity, that all of this energy and attention has amounted to a temporary swell instead of a sea change. So gender equality is within our reach, though far from equality. As I said, it would take about 5 generations for us to become equal. But what can we do to dismantle these barriers to women's professional advancement? There are stereotypical representation of women in the professional world. There's sexual harassment and discrimination at workplace. Women spend 2 times more time on caregiving than men. Fast track women in priority sector is very important. Blaming on the pipeline that not enough qualified women are present. I just had a conversation with one of the top management at our hospital when I asked, why are you not identifying a woman for this position? And he simply said, oh, I have not found a qualified woman when there are plenty of qualified women around. Pipelines are designed that way, not enough to get them into a career path, if not empowered, de-bias at the workplace, pay transparency, international, how work is assigned, redesigning the process for promotions, and amplifying the external pressure. At Aga Khan University Hospital, we had a conference on gender equity and women in leadership in December 2nd, 2019. And this is a hospital, Aga Khan University Hospital. Aga Khan is famous for its nursing education, and they have privileged and empowered women to come into neurosurgery. In Pakistan, the nursing profession was not considered a noble profession as it's all around the world. And AKU took the lead in 1980 and brought the best quality nursing education in Pakistan. And so far, as you can see, there are about 4,300 grads in Pakistan and 2,388 grads in Eastern Africa, because Aga Khan University Hospital is in 4 countries in the world, and everywhere the nursing education is on rise. And it developed an economic impact report, which said that transforming the nursing profession, catering career opportunities for countless women, and 2/3 of the AKU students and half of the AKU senior faculty should be members. This is the gender balance in my academic institution, in which there are about this many numbers of total colleagues, which are 15,957. And as you can see, that the ratio between the male and female is almost equal. It's about 58% and 42%. And these are the numbers. These are the numbers in Pakistan, East Africa, and other institute in AKU. Somebody is, I think, needs to get muted. So we did a survey in Aga Khan University Hospital to understand the institutional gender equity initiative with a focus on leadership development for women. And as you can see over here, the survey was taken in Afghanistan, East Africa, Pakistan, and United Kingdom. Most of the responses, of course, came from Pakistan. Hello? Can everybody hear me? I'm sorry.
Yes, yes, Anila, we can hear you.
Okay, sorry, I just got disconnected for a minute. So the male to female ratio was about 46 to 53. And when we asked, do you think gender equality in the workplace is important? And 92% said yes. When we asked them, have you received an introductory training or orientation on gender equality issues at Aga Khan at our institute, 90.3% say no, that they have not received an orientation on gender equality. And that's the point that I want to make, that I think this, the idea of gender equality should become a part of the curriculum when any new employee or medical student is actually entering into an academic institution, because women are there, but what we have to do is actually sensitize the men. And when asked, have you taken any gender equality related training or courses in the last 1 year? 92% said no. Is there an organization gender-wide gender policy? 63% in our organization say they don't even know if there is a gender policy. And when asked, do you believe gender equality fits with the image of organization? 40% said yes, and 30% said to a moderate extent. Which tells us that the hospital does have a vision of gender equality, but as you said, that a lot of people also do not have any idea about any courses or any gender-wide policy within the organization. When asked, are gender issues taken seriously and discussed openly by men and women in our organization? Only 11% said to the fullest extent and 28% to moderate extent, which tells me that a lot of gender issues that happen in organization are put underneath the carpet. And most of them are usually harassment kind of issues, because most of the time they are done by somebody who is so senior and so higher up in the management that the women actually do not want to take up these issues to the higher management because they believe that it's going to ruin their career. When asked, are you aware of the sexual harassment policy? 64% said yes and 34% said no. And we said, when we asked, have you read the policy? 56% said no and only 42% said yes. So that's about equal. When asked if you experience sexual harassment or gender bias discrimination today, would you feel comfortable reporting it? 39% said to the fullest extent and 20% said to a limited extent only. So which tells that only 40% of the people are actually comfortable talking about it, and 60% of the people are not comfortable talking about it. And when asked, can our organization do more than it's currently doing to promote gender equity, 50%, almost 43% said yes. And are there any proactive strategies implemented to recruit or promote women into senior positions? 16% said yes, and 33% had no idea about it. Are career training development opportunities transparent? 28% said moderately. So this was what we learned from our survey was that any academic institution like Aga Khan University that has a medical school, a nursing school, an allied school, as well as a big university hospital of 800 beds, has a vision of gender equality. But a lot of people do not understand what it means, and that kind of education needs to be given to the employees and the medical student right from the get-go. Muhammad al-Jinnah again said there are two powers in the world. One is the sword, and the other is the pen. But there is a great competition and rivalry between the two. Then there is a third power, which is stronger than both, and that is of women. So what I want to talk about, I talked about general gender equity and equality in my institution in Pakistan. Now I want to focus on what is the status of neurosurgery in Pakistan, and especially on the women. So in Pakistan, there are about 114 teaching hospitals. There are about 45 neurosurgery centers. CPSP is our Center for Physicians and Surgeons, which gives us the degree that you can practice in Pakistan, have recognized about 30 neurosurgical institutes. 300 neurosurgeons are registered with the Pakistan Medical and Dental Council, 278 registered with the Pakistan Society of Neurosurgery, and 132 residents are enrolled. But are we enough? The population that we have in Pakistan of the neurosurgeons. So the population to neurosurgeon ratio in America is about 3,500 working neurosurgeons, although there are 5,000 neurosurgeons enrolled, but a lot of them are retired. For 300 million population, for Japan is about 10,000 neurosurgeons. For India is about 1,800 neurosurgeons for 1,200 million population. And for Pakistan, there's about 278 neurosurgeons for a population of about 200 million. Until a few years ago, there was no coherent group of women within the Pakistan Society of Neurosurgery, and female residents were not encouraged to enter into this discipline. There was no active participation of female neurosurgery residents in national or international meetings. And due to strict patriarchal society, there was no concept of women neurosurgeons within the society. There were no role models. There were no one push the women agenda forward. And female neurosurgeon residents has to face double challenge. Number one, to be accepted by the colleagues as equal, and then to be accepted by the patient as the skilled surgeons. About 4 years ago, at the Pakistan Society of Neurosurgeons, they announced the formation of the Women in Neurosurgery chapter. And since then, and I have been the chair of the Women in Neurosurgery in Pakistan up till recently. And we started a Women in Neurosurgery lecture series in our annual Pakistan Society of Neurosurgery meetings. We would invite one female neurosurgeon who would present her cutting edge work. And the whole idea was twofold. Number one is to encourage more medical students to come into neurosurgery. When they see women who are doing cutting edge neurosurgery work, they are role models, and female would feel that they can also do what these women can do. And the other idea was to sensitize men that the women can do exactly the same cutting edge work, whether national or international, as compared to their male counterparts. So now total neurosurgeons in Pakistan, consultant plus residents, we have about 300, and then we have about 60 females, and out of them 12 are now consultants. And we have about 48 female neurosurgery residents. And you can see this ratio is drastically different internationally. So as you can see, internationally for 20 males, there is only one female. For us, it's a 2.5 times males, we have one female. So as you can see that our numbers for female neurosurgeons have risen dramatically in the last 6 to 7 years. And more females are coming into neurosurgery and are becoming neurosurgeons. And hopefully the 12 consultants will soon become 50 consultants in few years. In the world, recently in March 2021, there was a neurosurgical focus that was dedicated completely to international women leaders in the world. And as you can see that, these are the women leaders in the world. The Yoko Kato, who is our silent warrior, who has been pushing the education for residents and medical students and females all throughout her career. Whenever I have seen her, she has been carrying bags of information, DVDs, books, distributing it to other people. Dr. Najia, who is actually leading it from the sub-Saharan Africa, webinars are given to promoting other women. Dr. Karen Marasco was one of the female leaders in neurosurgery who was the first chair women of a neurosurgery department in University of Michigan, and the first person who was a part of the American Board of Neurosurgery to take their examination. Dr. Deborah Benzel was the first person I remember when I was a medical student who started Women in Neurosurgery in America, and which led to many white papers, bringing more and more women in neurosurgery. And now even in the US, the numbers are drastically rising. Shelley Timmons is the first female president of the AANS, and Dr. Deborah Benzel has been advocating diversity in neurosurgery, been on global forum talking about it, and has promoted the diversity throughout the world. Dr. Kate Drummond has also been a leading female neurosurgeon in the world. So with that, I just want to end my talk by saying that there are obstacles. The lack of awareness, especially on need for gender equality by both staff and leadership, and policies on gender equity may be existing, but staff and management have not implemented the policy. There's a lack of evaluation that needs to be explored. Gender audits should be done and should be addressed in an internal organization process to understand the systems the way we did our survey, and what it's important that it should become a part of our DNA, and only then we can actually bridge the gap of gender equality and gender equity, not just into neurosurgery. I think neurosurgery is far better, but in the world, this needs to be done. Thank you so much.
Thank you so much, Anila. That was definitely very empowering. I hope a lot of participants and speakers here today would be definitely empowered by your presentation. Any of the panelists would like to give comments?
I think somebody raising hands. Please, anybody would like to speak directly? Your microphone is unmuted. Just speak now.
We can't hear you. We can't hear you.
Can you unmute your mic, please?
Meizu, it's Meizu Pro 6.
Yes, please unmute your mic. I promoted you now in the panel. You can speak if you like. Okay, maybe she has problem in the microphone.
Okay. Any comments or? If there's no questions or any comments, anyway, you can feel free to leave it in the chat box. I'm sure Anila will answer your questions. Okay, so I'll go on to our next presenter. Our next presenter is Dr. Gleb Danielov. He's from Moscow, Russia. He's actually the head laboratory of biomedical informatics and artificial intelligence. So this is going to be an interesting talk. He's going to talk on the rationale for artificial intelligence applications in neurosurgical research and routine. So, Dr. Gleb.
Dear chairpersons, dear colleagues, can you hear me well?
Yes, you're clear, very clear.
It's a great honor for me to participate in this seminar. I thank the organizers for this opportunity. That's a great privilege. I want to tribute my report to my teacher, Professor Alexander Potapov, who left us this May after a prolonged illness. He was an innovator to inspire many, many ideas. 30 years ago, he initiated a department of computer sciences at Burdenko Neurosurgery Institute, which is in Moscow, Russia. In recent years, he strongly supported the advancement of artificial intelligence in neurosurgery. I have to speak on a topic that doesn't appeal much to neurosurgeons, so let me start with its formal definition. A formal definition of artificial intelligence may be a mathematical solution which automates intellectual tasks normally performed by humans. At the same time, artificial intelligence is used to name a branch of computer science that focuses on creating intelligent machines that act like humans. In that way, it implies many smart technologies with human-like behavior. The examples of artificial intelligence are a computer vision, speech and voice recognition, text reading, and machine translation. What are the goals of using this type of computer behavior or human-like computer behavior in medicine? The most obvious, probably a general purpose, is the automation. Read medical texts, medical records, or medical scientific publications, judge medical images, and suggest clinical solutions much faster and more confidently than a doctor can do. That might be helpful, that might be a perspective. But what are the current use cases of artificial intelligence in neurosurgery? And is there any rationale for investing in that type of technology today? To answer these questions, we conducted a systematic review, which we finished a year ago. We reviewed the original research articles evaluating artificial intelligence. And additionally, we used topic modeling to objectify. Topic modeling literally is clustering articles by topics and identifying topic-specific terms. So we included 327 articles from PubMed in our review. On the slide, you see a tremendous increase in the number of publications on artificial intelligence in neurosurgery, which is going on today. The majority of studies were conducted in Neuron Ecology, functional neurosurgery, vascular spinal neurosurgery, and traumatic brain injury. So what were the goals of using artificial intelligence in that field? Let's start with Neuron Ecology. The main goals of using AI in Neuron Ecology were non-invasive malignancy grading, which is image-based, and the graph that appears on the right is just a set of words specific for the topic. That's the process of topic modeling. And I'm underlining the most important. Next comes non-invasive molecular diagnostics, also image-based brain segmentation and volumetric analysis, and prediction of treatment complications and outcomes, which sounds like a very traditional task. You see that the image analysis in Neuron Ecology is the most important trend. And as an example, in a paper by Ju and co-authors, machine learning algorithms were trained to guess IDH1 status in glial tumors based just on MRI. Another example is a work from Burdenko Neurosurgery Center. A computer can learn how to automatically delineate small tumors when planning a radiosurgery. You see that the auto-segmentation in this example is pretty close to manual segmentation performed by human. This slide shows the work or the results of another algorithm that automatically delineates the glial brain tumor. This work is being carried out in our global project to predict the clinical manifestations of glioma, first of all, motor deficits, just based on neuroimaging. as you see in this case, based on MRI data. Differential diagnostics is a topical issue in medical image analysis. This slide shows an example of fairly successful solution to differentiate true tumor progression and radionecrosis after radiation therapy for brain metastasis. The value of the area under the ROC curve you see here is close to 1, and it indicates that the authors managed to find quite a useful model for such a complicated problem. This is another study, another example of automatic acromegaly detection from facial photographs, an interesting example of non-invasive diagnostics. So, the first reason to adopt artificial intelligence in neurosurgery, as it is illustrated in neuroimaging studies, is the transition to the most non-invasive and safe technologies. Imagine a non-invasive tumor biopsy. You will say, it's just a fantasy. I agree with you today, but who knows what it will be tomorrow? In functional neurosurgery, epilepsy diagnostics, outcome prediction, automated seizure detection, and Parkinson's disease diagnostics were the main issues in using artificial intelligence. And in that area, EEG, electrocorticography, bias sensors, in addition to magnetic resonance imaging, became very important data sources. This is a typical study aimed at detection of seizure onset in each patient using intracranial EEG. Another example is focal cortical dysplasia detection using MRI and machine learning. And on the right, you see a study with accelerometry-based wearable sensors to detect tonic-clonic seizures. So, the second rationale for artificial intelligence in neurosurgery is a new evidence-based way to assess risks for adverse events. That is an essential component for decision support. The majority of artificial intelligence studies in vascular surgery can be grouped by 4 main subjects: aneurysm studies, intracranial carotid stenosis, arteriovenous malformations, and intracranial carotid, and intracranial hemorrhage. And there is a variety of topics in vascular neurosurgery. A typical task for machine learning in this field is vessel segmentation. However, there are examples adopt heterogeneous data, including clinical text, images, laboratory data, to be used in machine learning. So a whole block of structured and unstructured medical data. And machine learning can account for many factors that an expert can handle. That is the third argument. And the fourth, which advocates for investing in artificial intelligence in neurosurgery, is related. The consideration of patients' details in a model is a way of evidence-based personalization of care, which we are all interested in. At the Duncan Neurosurgery Center, we are doing a project on automatic intracranial hemorrhage detection and classification. We have some success in that. So what if the machine learning can take over a part of the doctor's routine? For example, annotate a medical image automatically, or count the number of lesions, or calculate their volume. That is an intellectual job, but it's still a clinical routine. How much time could be saved for the doctor? And let's get a couple of examples from spinal neurosurgery. We identified 5 main tasks for using artificial intelligence in spinal surgery. These are non-invasive ICP estimation, discharge, disposition prediction, weight classifications, classification complication prediction, and outcome prediction, quite traditional. Now, let's get into the examples. For instance, a big set of clinical features was used to predict postoperative complications in spinal surgery. You see the left image, and of course, image analysis was also utilized, for instance, to detect spinal deformities. A very interesting study on the generation of synthetic scans from magnetic resonance imaging, so artificial CT. That technology might prevent unnecessary radiation exposure reduce time to treatment, and save costs. And artificial intelligence can recognize critical anatomic landmarks in real time. For instance, when doing neuronavigation, which might be really helpful in microsurgery and endoscopic surgery. That's only an animal study that you see on the slide, but in the future, human application is quite possible. Artificial intelligence may be also applied not only to clinical data, but to scientific knowledge as well. This is the example of service, web service utilizing artificial intelligence to study trends in scientific publications devoted to spinal neurosurgery. Digital technology can simplify diagnostic procedures and shorten the time from the disease manifestation to the best treatment administration. If we substitute some of the expensive technologies to digital, if we take some work burden off the doctor, this also leads to cost saving. Finally, the tasks of machine learning in traumatic brain injury were quite traditional. These are mortality prediction, ICP, IBP, CPP, and autoregulation analysis, consciousness impairment, and TBI severe diagnostic stem, TBI outcome prediction. I'm representing Burdenko Neurosurgery Center, which is one of the biggest neurosurgical facility in the world and is biggest in Russia. You see the amount of data we collect due to our annual surgical activity. That's why the application of artificial intelligence is absolutely reasonable in our center, and we are really enthusiastic about digging in this topic. And I would like to say only a few words about that because it is in some way unique. At Burdenko Neurosurgery Center, we have a laboratory of biomedical informatics and artificial intelligence. You see the team on the slide. We are equipped with supercomputer and data storages. I would like to show some of our work as an example how a specialized artificial intelligence team can be incorporated into clinical facility today. In general, we are really enthusiastic about that at our center. So one of our key direction, which is underestimated now and which is not that popular in AI studies in neurosurgery, is artificial intelligence in automatic medical text processing. We proposed an algorithm to extract information from unstructured medical text. That's very important to, this technology is very important when you want to process a large amount of textual, unstructured textual data, and you have to prepare this data for machine learning. So you have to somehow extract the target variable. We published this algorithm and applied for a patent, and this is the example of how our technology works. You see the quality of using this method for paresis detection in clinical nodes, quite high values for area under ROC curve. We saw that using the combination of machine learning and human expertise can augment information extraction from text. We also made an algorithm for scientific literature classifications and received Best Paper Award and European Conference in Medical Informatics. So to conclude, I would like to say that the use of artificial intelligence is becoming a trend in clinical neuroscience and a separate niche in neurosurgery. However, the study series are not that big, and the clinical utility of artificial intelligence is still a topical subject for evaluation. And to sum up the rationale for artificial intelligence application in neurosurgical research, I'm showing all the points that I have discussed already and want to draw attention to the very last one. So the very last one could be any efficiency you may imagine coming from automation in neurosurgery. And this list is going to be continued. I would say that our current commitment is to add up to this list and figure out in which cases artificial intelligence is most useful in neurosurgery. That is the rationale for research in this field. Thank you so much for your attention.
Thank you so much, Dr. Danielov. That was definitely very exciting. And like you said, yeah, it takes a bit to understand. So is there any questions from the panel or from the participants? Maybe you all need time to to understand and think of a question. Great, it was great. I think Prof. Kato has a question for you.
Oh, thank you, Daniel. Thank you very much for your great lecture. So expectation and of the complication for some our treatments reach, maybe some we can expect of the results. I think it's very interesting. So yes, so maybe in future the AI come to the neurosurgery the more and more, I think. So what is the next step of the AI for the treatment of the neurosurgery? How do you think?
That's very interesting question. Nobody can predict the future, and no model is capable of predicting the future. But what I think is quite realistic nowadays, this modern technologies that we call artificial intelligence are mathematical solutions which can process a large amount of data, a large amount of clinical variables, factors, clinical features of a patient, and that gives you an opportunity to consider much more information that we were able to do with, let's say, traditional methods or human expertise. And that is the tool to compare risks for different patients and for different methods applied to one patient. And I do believe that the next step in developing artificial intelligence technologies are finding a good point of application. And I would start from risk assessment as it started in economics. And I would try to invest in searching the requirements for automation in neurosurgery. So any task which could be facilitated, solved with automation is a question to be discussed with artificial intelligence specialists.
Thank you.
Thank you so much. That's a great honor and privilege. Thank you for inviting me. Unfortunately, I need to switch at least for some time for another conference, but I'm very grateful to be here, and thank you so much again for having me. Thank you.
Thank you for joining us. Thank you.
Thank you, Danielov. All right, so we'll get on to our next speaker in interest of time. I'd like to welcome Professor Takeo Goto. Professor Takeo Goto will give us a presentation. Professor Takeo is from Osaka, and today he will give us a presentation on brain tumor resection by endoscopic surgery. Professor Goto, you can share your screen.
Okay. Okay. Can you see my slide?
Yes, yes, we can see it.
Okay. Today, I feel very honored to have the opportunity to present my work in front of you. Today's topic of my presentation is endoscopic surgery of the brain tumor resection. Recently, in the field of the brain tumor surgery, endoscope become an essential surgical instrument. Its panoramic, wide, and clear view largely contribute to the less invasive tumor removal. So today I will teach the two topics. One is endoscopic endonasal approach, and second is endoscopic keyhole transcranial approach. At first, I will show the endoscopic endonasal approach to the especially deep-seated central skull-base tumor. In the era of the transcranial approach, surgical access to the central skull base seemed very difficult. But recently, endoscopic endonasal approach dramatically changed the situation. This is a simple illustration through the transnasal route. This is a central skull base. The only obstacle to access this area is a bony structure like the clivus, pterygoid process, posterior clinoid, or petrous bone. So if we have the technique to adequately drill out these bony structure like this, we can directly access entire area of the central skull base without retraction of the cranial nerve or vascular structure. So the endoscopic endonasal approach now becomes a very effective procedure to the skull base tumor. I will show the several surgical case. This patient shows a visual disturbance, and MRI shows a retrochiasmatic craniopharyngioma. Posterior part of the tumor protruded to the posterior fossa, so transcranial access seemed very difficult. But if we observe this tumor by the endoscopic endonasal approach, we can directly access within the circle of Willis. In addition, if we drill out the posterior clinoid and upper clivus, we can entirely expose the margin of the tumor and can safely resect out all tumor. I will show the surgical video. Now already bony structure drilled out, and this is a upper clivus, and this is a posterior clinoid process. I meticulously and gently drilled out the posterior clinoid process. And this is a pituitary gland, and this is a medial wall of cavernous sinus. I mobilized the pituitary gland to the left side and then cut the diaphragm. This is a basilar artery, and this is an oculomotor nerve, and this is an oblique chiasm. This is the pituitary gland and pituitary stalk. Under the endoscope, we can directly observe the border between the tumor and the pituitary stalk, chiasm, or critical structure. So now we could safely dissect the margin of the tumor, not injure the critical structure. In this case, we could preserve the pituitary stalk and gland, and the tumor was totally resected out. And also we can preserve the pituitary function. This is the second case. This case is a diaphragmacellar meningioma. Attachment of the tumor is here and severely compress the central skull base and the hypothalamus. Patient shows a severe visual disturbance on both sides. To remove this, I also choose the endoscopic endonasal approach. Attachment of the tumor is here. So at first I choose the endoscopic endonasal approach. This is the tuberculum cellar, and this is the cella floor. After finish the bone work, I cut the dura mater and mobilize the pituitary gland to the right side. And this is the left optic nerve, and this is the diaphragm. This case already the diaphragm was devascularized and detached, so we can safely dissect the margin of the tumor from the vascular structure. This case tumor adhere to the PCOM, but endoscopic endonasal approach, we could follow the margin of the tumor. This is an oblique chiasm, and this is an oblique nerve. Finally, all tumor was resected out. This is an oculomotor nerve. But this case, a complete dural seal is very important. So we insert the fat tissue to subdural layer and put some direct suture like this. This suturing technique is very useful to prevent the CSL leakage. And finally, we cover the mucosal flap. Tumor was totally resected out and his vision improved and also pituitary function preserved. This is another case of the posterior crinoid meningioma. Attachment of the tumor was posterior crinoid. So attachment was here. So I choose the endoscopic enonasal approach. This is a pituitary gland, and this is a carotid artery, and this is a posterior crinoid. Direct exposure and removal of the posterior crinoid process is a very effective procedure to enlarge the surgical corridor. Now I remove out the posterior crinoid and mobilize the pituitary gland to the left side. This is the attachment of the tumor. In case of the meningioma, devascularization and detachment was very useful to remove the tumor. This is a pituitary stalk, and this is a optic chiasm. Finally, we dissect entire margin of the tumor and totally resect it out. This is a PCOM. This is a oculomotor nerve. Pituitary, stalk, and gland preserved, and all vascular structure preserved. Postoperatively, all tumor resected out without any deterioration of symptom. How is this case? This is a recurrent clival meningioma, but attachment of the tumor was lower clivus. So attachment was here. So I choose the endoscopic enonasal approach. Attachment was here. So I widely drill out the bony structure along this area and devascularize, detach the attachment of the tumor. Now I already drilled out the lower clivus and middle clivus. And this is a paraclival carotid artery. And now bony structure was totally resected out. So this is a dramata along the lower clivus. I coagulate and detach the attachment of the tumor. Fortunately, this tumor was not fibrous, relatively soft tumor. So we could gently mobilize and dissect the tumor from the vascular structure. This is a VA. And this is the abducens nerve. And this is a pons. I gently dissect. And this is the ichor. And this is the lower cranial nerves. Tumor was already detached, so we did not encounter the bleeding. So we could dissect under the very bloodless surgical field. This is a facial nerve, and this is a border between the brainstem and the tumor. I carefully removed. And now totally all tumor was resected out and all vascular or neural structure preserved. This is a recurrent case, but a tumor was totally resected out without any deterioration of symptom. This is another case of the recurrent chondrosarcoma, entirely involves the petrous bone. This is a carotid artery. At first, I planned the transcranial approach, but I consider it will be very difficult to drill out this bony structure through the transcranial route. So to drill out this structure, I choose the endoscopic enonasal approach. This is a pterygoid process. To go to the petrous bone, we need the trans-pterygoid trans-petrosal approach. I drill out the pterygoid process and expose the paraclival and petrous carotid artery. And this is a posterior clinoid process. I remove out the bony structure. This is a tumor around the carotid artery. This is a carotid artery. Then I drill out the abdominal bone around the jugular tubercle. Now I drill out the all abnormal bone, and this is a tumor lateral side of the carotid artery. And this is a tumor around the middle fossa. I gently mobilize the carotid artery to the lateral side and remove the tumor around the petrous bone. This is a tumor protruded to the posterior fossa. Now I removed and dissect the facial and eighth nerve, and I confirmed that almost all tumor was successfully resected out. Post-operatively, this is a carotid artery, and all tumor was successfully resected out, and abducens nerve palsy improved. As the next presentation, I present the endoscopic keyhole approach to the skull base area. One is I will show the endoscopic keyhole subfrontal approach, and then I show the endoscopic keyhole subtemporal approach. If we put the small craniotomy and insert the endoscope, endoscopic panorama view can offer the wide view around the paracella area. Usually, I put the skin incision just eyebrow and put the craniotomy about 3 centimeters, and then insert the endoscope. Under the endoscope, we can expose the olfactory tract, the proximal side of the Sylvian fissure, and also expose the third nerve, carotid artery, and tuberculum sella and optic chiasm. And then we confirmed we could drill out the anterior clinoid process and the tuberculum sella. After this cadaver work, we confirmed we can safely resect out the paracella tumor by the keyhole approach. This patient shows a visual disturbance on the left side, and the attachment of the tumor was a tuberculum sella. Patient age was relatively old, so I choose the less invasive procedure. The size of craniotomy is about 3 centimeters. And then I insert the endoscope. I gently mobilize the frontal lobe and expose the attachment of the tumor. This is the optic nerve, and this is the anterior clinoid, and this is the tuberculum sella. Under the endoscope, we can get the relatively clear surgical view and open the optic canal like this. This is a left optic nerve, and this is a tumor around the tuberculum sella. I gently coagulate the attachment of the tumor and perform the internal decompression by the QSA. And then I open the medial wall of the optic canal on the right side, and then remove the attachment of the tumor. Now I confirmed almost all tumor was successfully resected out, and both optic nerve was successfully decompressed. Postoperatively, all tumor was successfully resected out and her vision improved. This is the neuroanatomy holds a keyhole endoscopic subfrontal approach. After put some small skin incision, also we put small craniotomy with a diameter about 3 centimeters and gently retract the temporal lobe and insert the endoscope. During this cadaver study, we confirmed we can safely expose the tentorial edge and third nerve and trigeminal nerve. This is a Gasserian ganglion V1, V2, V3. And then after cut the superior petrosal sinus, we can open the Meckel cave. So after this cadaver study, we confirm we can safely resect out this trigeminal schwannoma. I put the craniotomy like this and insert the endoscope. This is a surgical video. The size of the craniotomy always about 3 centimeters. And then gently retract the temporal lobe. And this is a dura covering the trigeminal nerve. This is a V3. I cut the dura over the V3 and expose the neural structure. This is a superior petrosal sinus. I coagulate and cut. After cut this sinus, we can safely open the Meckel cave. And then we confirm the trigeminal nerve and trochlear nerve. After gently retract the trigeminal nerve to the lateral side, we can expose the tumor capsule. Under the endoscope, we can confirm the border between tumor and the neural structure. So we can safely dissect the tumor like this. Craniotomy was small, but we could get enough space to remove the tumor. Finally, all tumor was resected out, and postoperatively, his clinical course was uneventful. This is the recurrent chondrosarcoma associated with osteogenesis imperfecta. So bony structure was very weak. So I choose a less invasive procedure. The skin incision and craniotomy was same, and I insert the endoscope. This is the dramata covering the trigeminal nerve. And this is the tentorial edge. And this is the fourth nerve. The craniotomy was small, but we could get the clear and wide surgical view. So we could gently dissect the tumor of the brainstem or trigeminal nerve and fourth nerve. This is the oculomotor nerve, and this is the tumor. This is the trigeminal nerve. We can expose the medial surface of the trigeminal nerve, and also we could expose the brainstem. We carefully dissect the tumor, very gentle procedure, and resected out all tumor. Now we totally resected out all tumor. Postoperatively, all tumor was successfully resected out. And the craniotomy was very small. This is the last case. This is a very huge pituitary adenoma. So we plan the combined approach. endoscopic endonasal, and endoscopic keyhole approach. This is the keyhole craniotomy about eyebrow under the eyebrow incision. This is a left frontal lobe. We use the two endoscope. This is a surgical video from the transcranial side. I gently retract the frontal lobe and expose the tumor. This is the olfactory nerve. I carefully dissect the arachnoid around the olfactory nerve. And this is a stretched optic nerve. And this is a carotid artery. At first, I remove out the tumor lateral side of the carotid artery. And this is a surgical instrument through the transnasal approach. So we gently dissect and remove the tumor on both sides. This is a surgical video from the transcranial side, and also this is a surgical instrument through the transnasal side. This combined approach was very effective to remove out the huge pituitary adenoma. This is a surgical video from the transnasal side. Now I expose the anterior cerebral artery A2 portion, and this is the ACOM. I remove out and dissect the tumor from the vascular structure. This is a complicated tumor, but finally, almost all tumor was successfully resected out with preservation of the perforator from the ACA. And I insert the fat tissue and put some suture to prevent the CSF leakage. Post-operatively, all tumor was successfully resected out, and his vision improved. Today, I will show the two surgical techniques. One is endoscopic endonasal approach, and the other is endoscopic keyhole transcranial approach. So now the endoscopic surgery can be very effective procedure for removing the complicated skull-based tumor. Thank you for attention.
Thank you so much, Professor Koto. It was very interesting. So all your surgeries are done purely endoscopic, Professor Koto? You do not combine with microscopic surgery?
This case, just use the endoscope, not use the microscope.
Okay, thank you. Any questions from the panelists or the participants?
Yes, Dr. Sharon, thank you. Professor Takeo Goto, thank you for the great presentations and the awesome extraordinary work, actually. My first question is for you, Professor. That endonasal endoscopic, do you ask for the assistance of ENT surgeon, or you do it by yourself from A to Z as the introductory for the scope?
In our institute, when we perform the endoscopic endonasal approach, we perform by the two neurosurgeons.
Okay.
My assistant holds the endoscope and also use one surgical instrument, suction or dissector. And I also use two hands. So in my video, we insert 3 instruments.
Okay, so there's no role for the ENT team.
ENT team collaborate after the surgery, especially nasal care. Nasal care is very important. So After the surgery, I consult the ENT doctor and care the nasal cavity.
And my second question is, Professor, what do you think exactly is the superiority of the endoscopic endonasal over the intracranial or transcortical route, like those large supracellular lesions or meningiomas or the sarcomas? Why do you think the endoscopic would benefit more than transcranial or transcortical intervention?
Thank you. How to select the surgical approach is just depend on the origin of the tumor. Even the size of the tumor very large, but origin of the tumor is a central skull base. I prefer to use the endoscopic endonasal approach because all critical structure shift to the lateral side. So directly access the center of the tumor, we can safely resect it out. So I choose the endoscopic endonasal. Size is not problem. Origin of the tumor is very important.
That was smart. Thank you. Thank you, Professor.
I think now, Sharon, we proceed to our next speaker. Now I'm glad to introduce our next speaker, Dr. Heba Azzouz. She's an Egyptian woman in neurosurgery. Heba is one of my students. She's doing a great job in neurosurgery, and she's affiliated to the same university to which I'm working, to the Department of Neurosurgery at Cairo University. She's an assistant lecturer, and she's co-chairman of the Egyptian Women in Neurosurgery group. Heba, welcome. Are you ready?
Yes, I'm ready. Thanks, Professor Nasser, for the introduction. Thanks, Professor Kato, for the meeting and for the support, and for all the panelists for those great presentation. So allow me to take you for a quick trip to leave the brain and the tumors and the blood vessels a little bit aside, and to consider the mind and the thinking pattern. So first of all, I was given the topic, which is limitation in practice based on self-experience. So the minute I read the title, I thought the word limitation, I cannot digest it. I didn't like the word limitation. And I think here lies the problem, right? So what is limitation? Is limitation the external forces around you that hinders your growth? Or it's something inside you that pulls you down to grow? Something like a tether cord, for instance, right? So maybe if we change the narrative, maybe if we change just the way we look about things, and we change the word limitation into challenges, things might look different. The minute we see things as challenges, not as an obstacle, then it will be a way for us to grow stronger, to grow wiser. So instead of considering things around us as limitation or an obstacles, let's just consider it as a challenges, as a way to grow, to change our mindset, right? So to go back to the reality on the ground, could we have two subgroups for those challenges? Could we divide them into the community challenges around us and the individual challenges? Because as you know, everything around us, it's you and the world. So let's go to the community challenges. If we have a highlight on different topics, so we can consider one of the most common challenges around us is the financial challenges, right? So let me give you a few examples of how finance shouldn't actually stand between you and the way you treat the patient and the way you manage your work. For instance, in treating movement disorder, sometimes we can say we don't have the capacity for a deep brain stimulation. But what about ablative surgery? This could actually overcome the financial outcome. Sometimes we could say that we don't have a neuronavigation or we don't have an intraoperative MRI for assessment. So what about choosing ultrasound intraoperative for answering the question? And here's another thing. You need to ask the question, what do you want to do in the surgery? What are the tools you're missing? Because for instance, if you have an endoscope and I don't know how to use it, then this is actually not benefiting the patient. We're actually harming the patient. So the excessive amount of tools isn't the answer. The answer lies within you. A trained doctor can actually help the patient. So it's not about the tool, it's not about the finance. Another challenges we can have is the demographic challenges. Some countries might have a more focused type of disease, like vascular disease and moya. Other continents might have a developing disorders like movement disorder. So how can we overcome it? The interaction between communities, between continents, between individuals is the only way to overcome it. We need to channel our information. We need to join all information for only one purpose, is to serve the humanity, is to have a better outcome for our patient, is to add something to the science, right? Some of the most common challenges nowadays we have is the pandemic. A lot of people might consider it as a huge obstacle. But think again, aren't we having a webinar right now? Virtual learning? We can always use the obstacles around us for another way to change, to grow, to change our mindset. And this is the only way we can be better human, right? So just changing the narrative, just changing the way we look at things will give us the answer. Asking the right question will give us the answer, because answers are already there. It's the question that we need to ask. So let's talk about a few little things about the community that we need to tackle. Learning. What is learning? The basic form of human learning is trial and error. But I don't think this is an effective way in treating a brain. And this is not an effective way in helping someone, right? You don't want to try and error. So learning has to be conducted. We have to learn from the experience of others. We need to read. We need to channel all those information. And let's not forget that learning is a curve. It's up and down. And the most important part is integration of this knowledge into the society and our platform, right? And we have to remember ourselves that learning is not a plateau. You don't reach a level which is plateau. That's exactly the same way as the heart. It has to be dynamic. The only time the heart is plateau, it's when it's dead. This is the exact same thing in science. Science can never reach a plateau. Your knowledge can never reach a plateau. It has to be always dynamic. Sometimes you will feel confident about the knowledge, and sometimes you will realize you know nothing. And this is the exact moment that you will learn another thing. This is the exact moment you will grow. The minute you know that you're missing a lot, the minute you know you're wrong, this is the only way you can grow better. So what is it to teach? I'm afraid to ask, are we only showing the bright side of the moon? Are we only showing those marvelous surgeries we have done, the huge number of cases that we're doing? Are we showing this complicated tumor that we've removed? What about the dark side of the moon? What about complications? We need to talk about it. And instead of talking about craniopharyngioma, endoscopic versus microscopic, or resection versus Ommaya, we need to talk about the complication that we face. And while we talk about complication and how to avoid it and how to manage through the rough time, is the only way we can improve the quality of life of patient. And instead of getting a beautiful post-operative MRI, we need to have a patient that is back to the community, functioning and serving and happy with his life, instead of just avoiding the negative side or the black side of the moon, right? And as Einstein said, failure is just a success in progress. We have to keep going. We have to show this side of our way, right? So why to teach? This is something. Ask your question again. What are you doing? Are you just here to justify yourself, to prove that you can do things, or are you here to add something to the community around you, to the people around you? Teaching is the highest form of understanding. If you don't understand it, then simply you cannot explain it. If you understand things simply, you will explain it simply. And this is the very easy way to channel this information to help growth of other things. Let's talk about something that I think it's the most important and the most crucial thing that we have to highlight over and over and over. It's mentorship. And in my idea, mentorship is not a teacher and a student relationship. All of us need mentorship. All of us, regardless of our degree, of our position, we need mentorship, because it's simply like a feedback. It's like you need to go to have the feedback, just like a pituitary gland, right? It has to have a feedback from the body. Is it doing okay? Is it doing wrong? What should I change? What should I focus on? What should I stop? How to think differently? So mentorship should always be our key point. We have to help each other to grow. We have to communicate. We have to gather along together for a better outcome for humanity, for a better outcome for the patient, for adding to science, for adding to knowledge, for being an integrated part in the society. So learning and teaching and mentorship are just the two sides of a coin, right? So let's go back to the other level, individual level. So what are the challenges that you might see as a human being, as an individual, as a person? Some of the things is self-based learning. You know, something about self-based learning is sometimes you will learn from here and from there, and this is a very important asset. But this makes you sometimes look like a collage. Some people are good with the collage. They can gather a lot of bits and pieces around them, but this doesn't work for everyone. So we need to have an evidence-based learning. We need to have a guidelines for the teaching. We need to know what to teach, how to get this young medical student to be an effective doctor, to treat the patient, right? So, and I don't think that adding the information to his mind or to his brain is the right way, because we also need to know how to think, how to have a critical thinking, how to, when we face a situation that is hard, that we don't know how to do, to manage instead of being stressed and to pull back, right? So another thing is a closed mindset. What is a closed mindset? We all need to do is to have a paradigm shift. We need to think, what is limitation and what is disability? What we can see is the Paralympics. They are actually the living example of that disability, and challenges are only in your mind. Some people have the disabilities or the challenges as a visible and physical disability or physical challenges. Sometimes people have it invisible, but the only disability we have is in our mind. Not only in sports, they have grown to have a very huge impact. Also in music, Ray Charles, Manito Ito, all of those people have actually, and the list is infinite, even in science, even in literature, like Stephen Hawking and all of these, right? So remember why I actually started. Remember why you started. Remember why you're here, all right? Because the only reason you will have ممكن الصوت ثانية واحدة؟ باشا ممكن الصوت؟ ممكن الصوت؟ So the only thing you need to do is to remember why you're here. Because if you know the reason why you're doing this, the reason why you're standing for 10 hours in an operation, or you're having a long shift, you will actually endure anyhow. You will know how to manage. You know why you're here. So remember again, the only limit is you. The only limit actually we need to focus in is when our limitation in resecting a tumor. This is the only limitation. When shall we stop in resecting a tumor? This is the only limitation. And remember, what's your priority? Is your priority yourself or having a community and advocating for safe lives for everyone around us, for the patient, and even for the communities other than this? Thank you.
Thank you very much, Heba, for this great presentation. And I think, Sharon, you have any comments? We still have our last speaker. But before proceeding to our last speaker, I'd like to ask if anybody from the panel would like to say any comment about this interesting talk.
Hiba, your presentation was good, very, very, very inspiring, right? I think the take-home message to all the young neurosurgeons is to understand, like what you said, the limitation is what we put on ourselves. And something I've learned through many years, I mean, many years in neurosurgery, and even through my residency, that basically it's like what you said, is the limitations we put on ourselves. And I think there's no limit to what we can do if the main thing is we believe in ourselves. All right. Once we believe in ourselves, then we have others who will believe in us. All right. And I think that's what's most important, and to persevere. Never let anyone say, you know, you're not good enough or you can't do it. All right. It's you yourself who has to tell yourself. All right, Hiba.
Yeah, Dr. Sharon, I also want to thank Hiba for this nice talk, Hiba. I can see from your eyes the struggling during your residency and training. and how much you're fighting to present in a very efficient way. And we do appreciate that power in you and the challenge you see in your eyes and how you want to make the best of you all the time. Dr. Nasser, I think you have a very a hard-working student. So Hiba, keep on, and we're all side by side during this hard journey. Thank you, Hiba.
Thank you, Rita, very much, really, for your kind words. Thank you very much. I'm also proud about the presentation of Hiba, and I'm always asking Hiba to work with her colleagues in Egypt, the Egyptian women in neurosurgery. We already constructed or created this group, and Hiba is working hard, and she's co-chairman of this group of Egyptian women in neurosurgery. We are expecting from you more presentations, more collaboration, and with all your team, please call me and contact me if you have any problems. Our organization is fully supporting you, and Professor Yuko Kato is also fully supporting all of you. Thank you very much. Sharon, would you introduce our last speaker, please?
Our last speaker, okay. So our next speaker is Professor Yuko Ohara. Professor Yuko Ohara will be speaking today on endoscopic spine surgery. Yeah, thank you, Professor.
So, yeah, good afternoon, and Africa, and good evening in Japan. I'm Dr. Yuko Ohara, Japanese neurosurgeon in, what is this? Working at Juntendo University. First of all, I would like to say congratulations for all the members of WIN to have this seminar. The title of this seminar is Current and Future Directions in Neurosurgery. Please let me allow to say many thanks to Professor Kato and Professor Nasser for giving me good opportunity to talk my subspecialty as one of the future neurosurgeries. So we are very behind from the schedule, so I'll start the lecture. Can you see everything? Is it okay?
Yes, yes.
Okay.
It's fine.
Oh, wow. I'm sorry. Okay, so in this lecture, I will talk about endoscopic spine surgery. In Japan, we have two kinds of endoscopic spine surgery. One is endoscopic assisted spine surgery, and another one is full endoscopic spinal surgery. I'm talking about full endoscopic spine surgery. And I'll move to the history of the endoscopic spine surgery. Think about the history of the endoscopic spine surgery. We have two streams. The first one is reached to the transforaminal method. The beginning of this method was percutaneous nucleotomy. This method was started by Dr. Hijikata, Japanese orthopedic surgeon, in 1975. He decompressed disc space. Then root compression of the herniated disc was improved in direct decompression. And we had to wait the single portal endoscope reported by Dr. Anthony Yang. Then we can start the full endoscopic spinal surgery. He reported percutaneous endoscopic lumbar discectomy, transforaminal approach. And the second stream was started from conventional discectomy, lab method, first described at Mixter and Ball. And many surgeons made the effort their surgery to be minimally invasive. One is micro lab. And then endoscope-assisted lumbar discectomy was developed by Foley and Smith. In Japan, this technique was continued by many orthopedic surgeons. But this technique is, we use this tube retractor and insert the endoscope here. And we can use all equipment, the forceps and bipolar and so on. And this endoscopic approach is reached to the interlaminar approach. After single coat endoscope was developed by Dr. Anthony Yang, some doctors used this single port endoscope for lab method. This is a interlaminar approach. And first, this single port endoscope method was called as percutaneous endoscopic lumbar discectomy. And we divided percutaneous endoscopic lumbar discectomy to 3 approaches. One is a transforaminal approach, like this, for the intracanalicular paramedian disc, and the interlaminar approach, like lab method, for intracanalicular disc, and the posterolateral approach for this line, for intra and extraforaminal pathologies. And nowadays, AO Spine recommended to call this method as full endoscopic spine surgery, so FESS. We will move to each approaches. First one is full endoscopic lumbar discectomy, transforaminal approach. We cannot do this approach without single port endoscope. This approach is unique for using single port endoscope. Endoscope is insert to intervertebral foramen, like here. And the insertion point is Cambin triangle. This triangle bounded by vertebral plate of the lower vertebral body and the superior articular process and medial border of the associated spinal nerve, like here. These VCLs show the insertion of the Cambin triangle, insertion of the needle to the Cambin triangle. After discography, the guide wire was inserted by this needle, and dilator and outer sheaths are inserted. First, we insert the endoscope into the disc space under the herniated disc, like here. Then, disc under the herniation is resected and the herniated disc fragment is resected. Then, if we need ventral of the facetectomy, will be drilled till the lateral recesses. We have some points to do the complete decompression. The aim of the decompression is to remove the herniated fragment, but discectomy. So, after setting the cannula, we use hand-down technique. This method is inside-out technique. First, we insert the cannula into the disc space, then withdraw and hand down of the cannula, allow to the find the herniated fragment. This scope angle is 25 degrees, so we can directly find the fragment by using hands-down technique. This case was a 52-year-old woman. She suffered from severe leg pain. MRI showed upward herniation disc at L34 left side. The VCL showed resection of the herniated fragment by outside-in technique. We can see here taker, and this part is completely axilla of the root. Here is the root, exiting nerve root, and we reject total disc fragment, and then completely decompression performed. And we don't need any damage of back muscle. And also we don't use nerve retraction. Second one is a posterolateral approach. We can approach this area by microscope also. Intermuscular approach is useful for this, but we cannot see real intraforaminal area. without destruction of the facet joint and the microscope. And also, we cannot manipulate the ventral of the nerve root under microscope and microendoscope. The insertion of the eye point can give us deep surgical field with minimum surgical approach related destruction. This case had a huge extraforaminal disc here, and endoscope is on the disc fragment around here. And we cut the ligament over the disc fragment, and we can see here exiting nerve root. And after the resection of the herniated disc, we can see the nerve root here, right side, out of the cyst, like this. And we checked the lateral of the root, and the lateral part of the root, under the root, herniated disc still, so we rejected more. The last one is interlaminar approach. This is the same approach as microlab method. Many authors reported this method, almost the same time. This case was a 42-year-old woman with L4-5 paramedian disc herniation. She had a 3-month L5 radiculopathy. So first, a dilator was inserted along the L5 spinous process to lamina, then interlaminar space. Right side interlaminar space was slight shallow, so we drew the L4 lamina like as microdissectomy. After we made the space, we could insert the endoscope into the lateral edge of the interlaminar space, and then this photo shows the L5 root compressed by herniated disc. And after the dissectomy, root was relaxed. This is another case of interlaminar approach. After insertion of the cannula into the interlaminar space, we could see a compressed root by the blue-stained subligamentous disc. Dissection of the root from the disc materials was performed, but very tough and very compressed, so it is not so easy. After dissection, we could see a herniated disc fragment directly, and then ligament over the fragment was cut by bipolar coagulator, and then very high pressure disc, so disc gashed out. After that, we rejected the fragment subligamentally. So we moved from the basic technique of the FED to advanced technique. FED is the most minimally invasive technique about surgical approach related damage, but also we can operate by microscope when we don't mind the destruction of the back maxilla and bony structure, include facet joint. Next, we will move to a special situation where FESS gives us large advantages, such as disc herniation at the foraminal area, real intraforaminal area, and the midline huge lumbar disc. In this special situation, we don't operate with the usual posterior microscopic approach. About the foraminal area, we can decompress by Wills approach, as I said, former intermuscular approach. But we cannot decompress without facet joint resection around the real intraforaminal area. So we need the fixation surgery for a complete resection of the compression at the intraforaminal area. This video shows a microscopic approach for the L4, L5, S1 extraforaminal disc. Left side is cranial side and the right side is caudal side. This is a facet joint, and this is a transverse process. In this case, very fortunately, we could see a disc fragment under the root here. And the disc is very small, so disc was very small, so we could reject the disc fragment. But this is very oblique view, but we cannot see intracanalicular area, intraforaminal area. This patient was 37 years old cardiologist. He admitted at the hospital because of severe leg pain and on left side. In that hospital, microdiscectomy at L4-5 was performed because he had drop foot. 8 months after initial surgery, he came to our hospital because he still suffered from severe leg pain. He could not work as a cardiologist. MRI showed foraminal disc at L4-5 left. Even he started to feel drop foot, like here. And okay. And then we did L4 nerve root block, and this was temporarily effective for his leg pain. Then we did the FED posterolateral approach at the L4-5 left side. First, we made the enlargement of the cambien space safety triangle. After that, we inserted the cannula to the cambien safety triangle. Root is covered by the cannula left side, and this is a fragmented disc. And after bulge disc was removed, this nerve root is coming back to the original position. Here, we rejected the disc material. And this case was a 58 years old woman, had a severe foraminal stenosis by osteophyte, like these. And this VCL showed a lateral facetectomy of the L5-S1. This is osteophyte, and we could see here a stained disc, so around here. And we can see a facet joint here, so like here. And then we did the decompression by using the drill. And after postoperatively, this foraminal area is enlarged. So next one is a central fused disc herniation. This is one of the difficult situations by microlab method. Sometimes fixation surgery is selected because we need to make enough space for resection of the herniated disc. Fixation is for iatrogenic instability, and transdural approach is selected for this situation, but the risk of the adhesive arachnoiditis will be. Especially central disc at a higher level is difficult to operate by microscope because the traction of the taker causes neural damage. This case was a 70 years old woman with bilateral leg pain. She could work just 10 meters. MRI showed central fused disc at L2-3 level. This high-level transforaminal approach is very easy because The width of the ventral vertebral body is narrow compared with the L5, and intervertebral foramen is wider, and also the shape of the vertebral body is like this heart shape. So we inserted this outer tube here, like this shallow angle, and VCR showed the end of the surgery. Here we could see a PLL, and the fragment disc was totally removed, and the pulsation of the dura mater, we could see a dura mater pulsation. Next, I will talk about the possibility of the interlaminar approach. This case is a 62-year-old male with neurogenic intermittent claudication. Neuroimages showed lumbar canal stenosis at L4-5, and the most cause of the compression was bony stenosis like this. We could decompress by the percutaneous endoscopic lumbar laminectomy. This is almost most minimally invasive lumbar decompression surgery. And then drilled out lamina. After that, we touched the pedicle, contralateral side, and the attachment of the yellow ligament. Then we drilled out a large area by this very small equipment. We could see a very good decompression like this. And this case was a 29-year-old male with a calcified disc at L4-5 left side. We can use the navigation system for this FESS surgery. We can confirm real-time information by navigation monitor. And in this case, we attached the navigation system at the FESS drill, like this. So we could decompress calcified disc safely and certainly, like this. And also now we are using this percutaneous endoscope for the CVJ pathology. Ventral compression factors of the craniovertebral junction are one of the difficult pathology to make decompression. Especially basilar impression is difficult to treat. We cannot do enough decompression when we do posterior decompression and fixation. So we started to use FESS system for these pathologies. This is basilar impression, and after fixation surgery, we decompressed here. This is the intraoperative view. We insert the cannula under the usual transverse skin incision for anterior cervical surgery, and the scope was inserted to the odontoid base. Then start the drilling. And this is the odontoid process. This is in the odontoid process. And drill the, this is the dorsal side and the tip of the odontoid process. We could decompress the lateral side, dorsal side, and the tip of the odontoid process. And we could see a pulsation of the tectal membrane. So we'll think about the merit of the FESS system. First, many doctors mentioned minimally invasive technique, small skin incision. The most important point is the minimal damage of the spine structure, especially for back muscle. And also we can operate under local anesthesia. Second point is under continuous irrigation. This has merit for decreasing infection and avoiding heat injury at drilling and hemostasis. Final one is the situation I told in the seminar, we can operate without fixation surgery. The point is minimum destruction of surround tissue. So how about the demerit of the FESS? As a special complication, such as post-operative dysesthesia caused by executive nerve root injury, intracranial hypertension caused by irrigation, and kidney injury, colon injury at needle insertion will be. And we need special training for this difficult technique. Many authors reported the shallow learning curve. So I close my talk. In this paper, we showed the current situation and the possibility of the full endoscopic spine surgery. Following the trend of the minimal invasive surgery, endoscopic surgery is widely accepted and it is not special procedure anymore. Talking about the merit of FESS, minimally invasive surgery is allowed to emphasize. We believe the most important merit of this surgical method is available to approach with the minimal surgical approach related damage. On the other hand, however, open surgery is accepted as a safe and promising procedure. Even though FESS has an advantage, we should also provide the same safety technique. Thank you very much.
Thank you very much, Professor O'Hara, for this great talk, another excellent presentation. All the presentations today are really outstanding. Now I would like, I think we will have time for discussion. And I think we have Professor Hisham Basuni from Germany. He would like to make comment. We have Natalie from Ukraine. She's raising her hand. But let me first introduce our last speaker because Sharon didn't speak and she was insisting to be the last one to see if there is some time remaining. Thank you, Sharon, for this great initiation. And I would like to introduce Dr. Sharon Stayophilas. She's from Malaysia. She was organizing this webinar with me and Leo, and we organized together another meeting, I think maybe 1 month ago. And Sharon is now, she's the chairperson of the Women in Neurosurgery in the Asian Congress of Neurological Surgeons. Thank you very much, Sharon. And we will be happy to enjoy listening to your talk. And after you finish, we will open discussion among all the panels. Thank you.
Thank you so much, Professor Nasi. I know it's quite late. It's quite late here in Malaysia. I think it's much later in Japan. I'd like to thank so much Professor Kato and Professor Nasi for getting me involved in this webinar, and also with Liu to include women in neurosurgery and also young neurosurgeons. I think both these two cohorts are actually under, we are still a small cohort in this society. So we hope to one day make our mark. And I think we have to start off one day. So we have already started off. So basically my talk today is the role of organizations in the advancement of women in neurosurgery. I think organizations play a very important role. For example, like today, all right, this a combination of a few societies together and associations and Congress have come together to actually give us a platform for us to present ourselves. So basically an organization is a group of people with a particular purpose. Here you can see some of the few organizations that started off early, including women in neurosurgery, such as the WFNS, ACNS, and then now CAANS, and also AASNS. So there are a few organizations now actively including women, and also having sole webinars, which is basically run by women. So about 80% to 90% of the presenters are women. And it is through these webinars that you get to expose yourself that a lot of women neurosurgeons out there are actually doing a lot of work, a lot of good work, but they just don't come forward. Maybe not given the opportunity, but it's great that today the organizations are giving them the opportunity. So Karl Marx said, social progress can be measured by the social position of the female sex. So I hope that the neurosurgery fraternity one day can say that we have progressed by making sure that the women in this fraternity have the same position as the men here. So first of all, organizations need to provide opportunities for women to showcase their values to others. And this can be done like what we are doing today, having webinars. Here you can see webinars that have been presented in the year 2020 itself. And 2021, we have had quite a few webinars where the presenters have mainly been women. Here you can see WFNS WIN presentation. Here you can see a presentation that we had together with Professor Nasser, where we actually inaugurated the WIN Egypt. Here is another joint symposium, WFNS WIN, which they just had it at the end of April. And here again, lately, the WFNS Neurohabilitation and Reconstructive Neurosurgery Committee for the Asian Australization Society of Neurological Surgeons have been starting to have webinars where they have also included women neurosurgeons. So here you can see the speakers are all women. That's the start off. The other role is supporting women neurosurgeons with a powerful network of people who are willing and able to speak up when they achieve something impactful at work. I think this is not very clear in our fraternity, which needs to become more available or more transparent. And this publication, a journal publication, which also Anila highlighted in her talk, is in the neurosurgical focus in the month of March. So that whole journal just highlighted on women neurosurgeons. And I think it was really great that Neurosurgery Focus gave us this opportunity to highlight ourselves. And in that article, you will actually see there's an article on some outstanding women, including Professor Yoko Kato, and their contributions to the world of neurosurgery. So other roles of organization is sponsorship. So purposefully promoting women neurosurgeons and creating a visible opportunities for them to accelerate their path to leaderships. So women are mentored, a lot of us are mentored, but we do not get sponsorship easily. And here is our own undertaking under the guidance of Prof. Kato. We actually offered a scholarship for a best presentation in ACNS, WFNS. It was a combined effort where the best speaker was given amount of money contributed, and she basically contributed by Prof. Kato. She's so kind to us actually, and managed to give it to one of the presenters who was able to present her paper in WFNS in Beijing in 2019. So I believe organizations should adapt a new mindset about women in leadership roles. We see the world changing. In the last 5 years especially, I could see that women have taken a bigger role in organizations, taken a bigger role. For example, even if you watch a movie today, you will see the women are lead roles, okay? And there are people watching these movies, right? So we are no longer behind a man, but now we are becoming lead actors. So it should be the same in our organization. So here you can see some of the famous leaders in the Neurosurgical Society. A lot of women have come and gone, who've left a great mark, who've given us a lot in this society. So organizations that will succeed in advancing more women when they listen, understand the challenges of diversity and bias. The perfect example is today's webinar, where I see Prof. Nasser has put a lot of effort because he realizes that Egyptian women neurosurgeons are still a very small number and he wants to bring them forward. We want to provide total transparency and take proactive responsibility for what must change. All right. And the only way women neurosurgeons can make a difference is if we are 30% of the cohort in this fraternity. It is only when we come up to this 30% cohort can we make a change. And at the moment, if you look at our numbers, we are only about maybe less than 10% in the whole world. So the organizations first started off with WIN was founded in the AANS in 1989. You can see here by Dr. Deborah Benzil. And from here, you can see this is their publication, which they put out this year in Neurosurgery Focus, where you can look at the numbers when they first started off, and you look at the numbers in 2010. So you can see in 2017, the medical students is about 50% female. But however, the number of neurosurgeons that are women in US and in the year of 2017 were only 8.4%. So if you look at a very developed, you look at an advanced developed country, we can see that even in that country like US, the number of women neurosurgeons are still very low. Okay, so you can see the world statistic shows the ranges between 5 to 10%. So we are very far off from that 30% that we need to achieve to make a difference. And you can see here, even in Africa, the highest number still comes from Algeria. And in the other countries, it's still a very small number and very far behind from that 30%. Okay, so ACNS WINS chapter, we first inaugurated in 2018. Of course, our founder is Professor Kato. She's a strong believer of women in neurosurgery. So our main aim is to educate, inspire, and encourage women in neurosurgery or who want to become a neurosurgeon. So remember, it's not just for us neurosurgeons, it's also for our residents, and it's also for our medical students. So we want to inspire this young generation of women to take up neurosurgery. So these are the things we want to do. Is one, we want to identify the obstacles. All right, we want to give them training and development. We want to mentor, foster growth of female neurosurgeons, give them awards and international paper presentation, and finally, eliminate discrimination. So women to be together, to be the same, and to become one day a growing force in this neurosurgery fraternity. Here you can see in 2018 when the first inauguration, right? You can see Professor Kato, and you can look at here the women, the togetherness and the joy of being together and knowing that we support each other. Here was in WFNS Beijing. And this is the WIN Malaysia. So actually in Malaysia, we are quite a large number. We are about 18%. And I think this year we had 2 more female neurosurgeons. The exams were just over. And I was lucky enough to be proud enough to say I mentored one of them. And she made me proud because all the male neurosurgeons said she did very well. So we are about 18% in my country, and I see a lot of them joining. I have medical students that come to me every day and ask me, how can I become a neurosurgeon? So that is inspiring to myself too. And I'm proud of where they are today, of the women neurosurgeons in my country. So in summary, to give organizations to make a change or to make a difference, you need to recruit more women into neurosurgery. You have to promote mentorship and sponsorship for women. You have to develop women leadership opportunities. So you have to give us women leadership opportunities. You have to engage women in neurosurgery globally. And finally, you have to support women. So Nelson Mandela said this: freedom cannot be achieved unless the women have been emancipated from all forms of oppression. Thank you. So, Prof. Nasir, maybe we can open the floor for questions from the panels, from the participants.
Thank you very much, Sharon, for this great presentation. And I think we have a lot of discussions. Hisham Basuni from Germany, thanks for joining us now. I think you'd like to make a comment.
Yeah, thank you very much for that I could join this great event. Thank you, Professor Kato and Professor Nasir. Thank you very much. And I'm a bit exotic because I'm coming from Europe. I'm working in Germany, being director of 2 neurosurgical departments at 2 academic hospitals in Bavaria. And to the last very beautiful talk of Dr. Theophilis, I can say that in one of the neurosurgical departments I'm in charge of, I have surpassed the 30% because I'm 50% of women are working in my department at one of the hospitals, and one of the women is my deputy there. So I'm on the good way and good line. And I can say that actually I've very good experience with this, and my philosophy is not only equal gender, but also a mix of nationalities. So one of the women is German. I'm working in Germany, and the other one is from Holland, but she's Taiwanese in origin. So it's and the other guys, one is from Syria, one is from Egypt. So it's a mix, and they're working very good together. So I'm supporting your idea, and I think there's no doubt or no real doubt or reason for not letting more women experience or joining in the departments. The main problem may be the applications. I've got much more men who are applying for such posts than women. So so the choice is a bit difficult. Thank you.
Thank you very much, Professor Hisham Bassiouni. Professor Hisham Bassiouni, he is in Egypt, but he is Egyptian, but he's practicing in Germany. We are always proud of you, and he's always supporting our series of webinars and contributing with us each Friday, usually helping me moderating our webinars. Thank you, Sharon. Would you like to moderate the discussion, please?
Thank you, Prof. Nasir. I think we can open questions for Prof. O'Hara just now. I think he gave us an excellent presentation. Something a lot of us who are interested in spine, we realize that they are moving away from open surgery to endoscopic surgery. I think it's the latest thing, especially for young neurosurgeons. It's something that I think we should seriously look at. Any questions?
Maybe I can comment on this talk.
Yes, please.
Thank you very much for this future direction or current direction already. But microsurgery actually is not destroying the joints at any level. So it is a question of technique. Of course, if you've got a bad endoscopist and a bad microsurgeon, you are destroying, and you are maximal invasive. But the point is to be minimal invasive, either by the endoscopic or microsurgical approach. So one of the points, messages was that microsurgery is destroying, and it has difficulties in some levels. Actually, you can operate on all levels without destroying and without causing instability by microsurgery.
So Dr. Nazil, just I want to say, because I want to ask Dr. Goto, he recently became a chairman of the Osaka City University, and he experienced both sides. So open surgery, because he experienced so many skull-based, such very tough cases. Recently, he moved to the endoscopic skull-based surgery. I think he experienced both sides, the open surgery and endoscopic minimally invasive. I think what's the difference and what's the result? Maybe just you can say some comment, please.
Thank you, Yoko. In the field of the skull-based surgery, we need the both technique, microsurgery and endoscopic surgery. In some cases, microscopic meticulous dissection is very important to preserve the cranial nerves or vascular structure. And in some cases, endoscopic surgery can give a less invasive procedure. So especially in field of the skull base, we neurosurgeon master the both technique, endoscope and microscope. And after master these two techniques, we can select the approach, depend on the case. I think it's very important. If just use one technique, microscope, it's not good. Also, just focus the endoscope is not good for the skull-based surgery. So I just comment for the young neurosurgeon. We have to master both techniques, endoscope and microscope. It's my comment.
Thank you so much.
Thank you very much. Any other comments? I think now it's time to close the webinar. I know it's late in Japan. It's 11:30, just half an hour before midnight. And we apologize that we extended the webinar for 30 more minutes. But actually, the discussion was very interesting. Now I invite Professor Yuko Kato to close this session.
Thank you so much. But today's webinar is, of course, more than 3 hours, I think. But for all young doctors, I think it's very inspiring. And also those message from the experts presentation, I think the all young neurosurgeon can reward to your patient. But I think we understood not only the minimally invasive, but also sometimes the maximally invasive treatment is very important for each case, I think. And also today's webinar is covered all fields, I think, besides of the women neurosurgical talks. And as for the women talks, just all the ladies neurosurgeons should have the confidence. Also, they of course include me. We do more research and also the practice, and also some big achievement for each subspecialty which they want in the future, I think. And also, of course, the lady neurosurgeon should have the taking care of the family, I think. So sometimes they need think about the balance, the work life balance, I think. Once again, I thank you very much for Professor Nazil and all organizing committee and the SNS members. I thank you very much, and also all speakers, which gave us a very excellent lectures today. So I want to close this webinar. Please, Dr. Nazil, make some comments. Thank you.
Thank you very much, Sharon. Would you like to say a comment before I close the session?
No, it's okay. Just I'm very glad that we have a platform here today that the women neurosurgeons can also share their views and also their scientific presentations. Thank you so much.
Thank you very much. And at the end of this webinar, I would like to thank great Professor Yuko Kato for giving us such opportunity to work together, Asians and Africans, and to make such very interesting and very important event, which was extended for 4.5 hours with all our distinguished speakers, with all our outstanding presentations. I would like to thank all our distinguished speakers. I would like to thank Sharon and Layo for helping me in organizing this event. I would like to thank all attendees. Thanks to all of you, and hope to see you all again in another occasion. Thank you very much.
Thank you very much. Thank you.
Thank you.
Bye-bye.
Thank you very much. Thank you.
Thank you, professors.
Thank you. Thank you so much.
Thank you, Professor Kato. Thank you very much. Thank you very much. We are honored. I'm honored really to work with you. Thank you.
We all honored.
Thank you very much. Good night. Thank you very much. Goodbye.
Thank you.
Thank you, Professor Kato.